أول شيء السلام عليكم، صباح الخير. آه معاكم محمد الجهني. اليوم إن شاء الله معنا محاضرة ال International Patient Safety Goals. بس دقيقة خلينا أعمل شير للسلايد. السلايد واضح؟ مبين معاكم؟ تمام، يلا أجل نبدأ بإذن الله. أول شيء آه أنا محمد الجهني. I have a master degree from Monash University, and I'm currently doing head nurse for medical ICU at King Fahd Hospital in Medina Munawwara. Today we're gonna do international patient safety goals, which is six elements or six goals. Has been recently focused more on the SIBAHI accreditations and many goals that's looking for patient safety. Okay. At the beginning, we need to know what's the patient safety. This is the definition of patient safety from World Health Organization. Patient safety is defined as the absence of a preventable harm to a patient and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. So here they mentioned the absence of a preventable harm. So there is something like called preventable harm and unpreventable harm. So here only the harm we are looking for that's preventable, like anything that may happen in the hospital. Within the broader health system context, so we are focusing here about the health system context. It's a framework of organized activities that creates cultures, procedures, behaviors, technologies, and environments in healthcare that consistently and sustainability lower risk, reduce of occurrence, avoidable harm, make error less likely, and reduce impact of harm when it does occur. So here anything that mainly focused in the hospital and may cause harm to the patients, we need to minimize it, or at least prevent it. So we have here some common sources of patients' harm. For example, first of all, medication errors. Medication-related harm affect 1 out of every 30 patients in healthcare, with more than a quarter of his arm regarded as a severe or life-threatening. Half of the avoidable harm in healthcare is related to medication. So, as we mentioned, there is avoidable harm that can be avoided. And here they mentioned the medication errors, maybe 50% of these harms that may threaten or make a danger for the patients. Secondly, there is surgical errors. Here they mentioned 0 for 3 500 million surgical procedures are performed each year worldwide. Despite awarenesses of adverse effects, surgical errors continue to occur at a high rate. So 10% of preventable patients' harm in healthcare was reported in surgical settings. This is, I think, big percentage. We imagine like 10% that occur for the surgical errors. So now we are doing the introductions before we are getting to the details and to the goals that may reduce these things or prevent these things from happening in the future. So we have to know everything's around to so we are now like getting an idea about the errors and about the weaknesses or the gaps that may harm the patients around the world. So then we have to implement the goals of patient safety or international patient safety goals that may prevent these harms. So here we have healthcare associated infections. And later on, one of the goals, it's talking mainly about healthcare associated infections, also about the surgical errors. So one of the goals that's mainly focused on the surgery and these stuff that may happen prior, during, and after the surgery to prevent these harms. So here, one of the things, one of the things, yeah. So healthcare associated infection with a global rate of 0.14%, increasing by 0.06. So each year. So every year we have 0.06% will be added to the 0.14%. So maybe in the future, we may find ourselves like getting 10% global rate of healthcare associated infections, or maybe getting a 20 with the years. So we have to work on them to prevent these harms. So healthcare associated infections result in extended duration of hospital stays. Imagine if you have a patient in the hospital and supposed to stay 7 days maximum to do any kind of procedures. So if he develop infections, what do you think, guys? He will maintain the 7 days staying, or there is possibility to stay more? What do you think? If he is getting infection, so we need to do some kind of a blood investigation to know, yes, possibility to stay longer, stay more, possibility to stay longer, yes. Yes, so we have to looking to do a blood investigation at the beginning. Then we have to do maybe empirical, or we are waiting for the result for the blood CS and the other cultures to diagnose what kind of infections these patients got to treat him. So the staying will be longer. So maybe up to 20 days, maybe, or double the days, like maybe 15 days to 1 more week. So the length of staying in the hospital will be extended. Also increased antimicrobial resistance. So we can't find any antibiotic that's sensitive for this virus, like multi-drug resistance. Sometimes we notice them in the hospital. Also, additional financial burden on patients. Some of them, they are, especially in globally, people, they pay their treatment payment. So it's not free government payment. So it may cost them a lot. Also, maybe cost the insurance company. Also on patients, families, and health system and avoidable deaths. So also about on the health systems, okay, we treat the patient, but sometimes we can't find beds for the coming patients. I have many patients, they are waiting in the emergency department, they are waiting for some beds. But unfortunately, these beds are occupied by patients got an infection from the hospital and they have to stay more. Also, we have sepsis. Sepsis is connected to as well to infections. So here we say sepsis is a serious condition that happens when body immune system has an extreme response to an infection. The body's reaction causes damage to its own tissues and organs. Of all sepsis cases managed in hospital, 23.6% were found to be healthcare associated. This is, I think, big amount or big percentage. These infections related found to be healthcare associated. So the healthcare practitioners or the hospital environment caused these things to the patients, and approximately 24.4% of affected patients lost their lives as a result. So the mortality rate has been increased because of the healthcare associated infection. Also, we have diagnostic errors. These occur in 5 to 20% of physician patient encounters. According to Dr. Reviews, harmful diagnostic errors were found in a minimum of 0.7% of adult admissions. Most people will suffer a diagnostic error in their lifetime. So they got a wrong diagnosis and they haven't been diagnosed well at the beginning, then they suffered at the remaining of their life. Also, we have here patient falls. Patient falls are the most frequent adverse events in hospitals. Their rate of occurrence ranges from 3 to 5 per 1,000 bed days. So if we keep some patients together, maybe if we imagine like every patient has to stay in the hospital 7 days. 7 days, we have like 10 patients in 7 days. This is 70. And if we have thousands, it means like 1,500 patients. There is among them 3 to 5 patients or 3 to 5 people, they will fall from the beds. And falling from the beds, it has some severe and negative consequences on them. Also, it causes injury for them. Also, it causes also related to the length of stay in the hospital. And more than 1/3 of these incidents result in injury, thereby reducing clinical outcomes and increasing the financial burden on systems. So we have one of the goals that's mainly focused on patient falls and about the strategies to prevent the patient falls. Also here, unsafe transfusion practices. Unsafe transfusion practices, also we have one of the international goals that's we will talk about them. It focuses about the effective communication and patient identification. So it may prevent or reduce the unsafe transfusion practices. So if we have to go with the good patient identification and effective communication between the healthcare practitioners and between also sharing the patients, it may not happen. So we say unnecessary transfusions and unsafe transfusion practices expose patients to the risk of serious adverse transfusion reactions and transfusion transmissible infections. Data on adverse transfusion reactions from a group of 62 countries show an average incidence of 12.2 serious reactions per 100,000 distributed blood components. So here we go. Also, patient misidentification. If the patient's misidentified, maybe, not maybe, it's 100% the wrong treatment will go to another patient. Also, maybe the procedure itself. We may find ourselves operating someone else. It's not the desired patients. So the patient identification is so important. And also we're gonna talk about it shortly. So here they say, also we are talking now about the statistics and the census that happened to get an idea, like failure to correctly identify patients can be a root cause of many problems and has serious effects on healthcare profession. It can lead to catastrophic adverse effects, such as wrong site surgery. Yeah, we mentioned area, we may find ourselves operating someone else, not the patients we are looking for. A report of the Joint Commission published in 2018, means like 6 years ago, identified 409 essential events of patients' identification out of the 3,326 incidents. It means 12.3% between 2014 and 2017. Okay. Also here we have unsafe injection practices. Maybe needle stick injury. It may cause some infectious adverse effects. Like each year, 6 billion injections are administered worldwide. And unsafe injection practices place patients and health and care workers at risk of infectious and non-infectious adverse effects. Using mathematical model, a study estimated that in a period of 10 years, from 2000s to 2010, 1.67 million hepatitis B virus infections. This is big number. Between 157,592 to 315,120 hepatitis C viruses infections, and between 16,939 and 33,877 HIV infections were associated with unsafe injections. So we have to do some precautions to avoid the unsafe practices injections, like one scoop practices. So usually we are saying don't recap the needle, don't return the cap of the needle to prevent So just throw them straight away to the sharps container. Also, don't be rush while you are giving or just extracting blood. Also, usually you have to do screening for the patients that's coming to the hospital, like doing serology for them to get an idea about whether they have some infectious disease like HIV or hepatitis. So usually we are encouraging to do serology for the patients. Here we go, like problematic areas in healthcare settings. What do we mean by medical errors? Medical errors are defined as an act of omission or commission in planning or execution that contributes or could contribute to an intended result. Yes, this is the medical error. So here they are saying an act of omission or commission in a planning or execution that contributes or could contribute to, usually it results in an intended result, in a result we don't like it to happen. Here is a report in 1999 says that, and this report has been disseminated or published by Institute of Medicine, estimated 44,000 to 98,000 patient deaths. You see this number, 44,000 to 98,000 patient deaths each year were a result of preventable medical errors. So we have to focus more about the strategies, about the goals that reduce these numbers. More recently, medical errors have been reported as the third leading cause of death in the United States. So the third leading cause in the United States is the medical error. Maybe we could say the using narcotics or drugs, maybe accidents, maybe coming first and second, but medical errors, it came as the third leading cause in America. So in addition to this direct impact on human lives, preventable medical errors are financially taxing on healthcare system. And yeah, as we mentioned earlier, it may cost or maybe cause a burden on patients, family, healthcare institutions, medical insurance. All of these will be affected if anything happen to the patient. Also, here we have a census about patient misidentification is increasingly being recognized as a widespread problem with healthcare organization. The National Patient Safety Agency, NPSA, has recognized patient misidentification as a significant risk within the NHS and one which needs urgent attention. So over a 12-month period from February 2006 to January 2007, the NPSA, the National Patient Safety Agency, received around 24,385 reports of patients being mismatched to their care. So we did patient misidentification around 24,385. This is the one reported, but sometimes there is something It's not reported at all. So maybe the number is bigger than this. It's estimated that more than 2,900 of these related to ID bans and their uses. Here we have the serious hazards of transfusion. Also here they are talking about blood transfusion that's caused harm to the patients. Data over 9 years shows that 71.5% of reported blood transfusion incidents involve transfusion of wrong blood to patients. So wrong blood to the patients. This means maybe we sent cross-matching or blood for different patients. So always we are encouraging once we extracting blood should be by two qualified nurses, and they have to put the patient stickers or the lab stickers immediately on the tubes. So to prevent the chance of errors. As here they mentioned 71%, 71.5% transfusion wrongly or transfused wrongly. The outcome of this included the death of 22 patients and major morbidity. For example, conditions requiring ICU admission. So if we once the patients get more infections and the case will be complicated, will become complicated, especially for comorbidity patients and patients they are coming with and they are fragile. So once they get infection from the hospital, it may cost them their lives. So, and also they may need the ICU admission. And so the extent to which patient misidentification happens is widely underestimated by clinical staff. So we are underestimated these things. So it's not important. Why do I know the patients now? You can't make sure about every patient. Sometimes the patients, they are leaving their rooms to another rooms, and some people, they are getting from different rooms to the different, they are getting to a room not belong to them. Sometimes old ages, and even for the young ages, sometimes they are getting there, some of the nurse. And you know that the procedure is commonly same in the hospitals. Maybe it's the chance of error, it may happen. So we have to do patient identification always. Once you, even if you want to give any update about the patient's health status, you have to introduce yourself and ask the patient his name if he's conscious, or if he's not conscious, we have to check the ID bands, whether you are giving a treatment or you want to just to say him any update about health status. You may cause harm for him. You are saying bad news to him. It's actually, it's not belong to him. It's belong to another patients, but because you didn't do the patient identification, or you didn't ask the patients about their names, so you got the wrong patient. So the following types of incidents have been reported, like administration of wrong blood drug to the wrong patient, performing a wrong procedure on a patient, mislabeling of a specimen. So we said we have to label them straight away, comparing the patient's file with the ID band, asking the patients to make sure 100% this is the right specimen for the right patients before sending them down to the labs. Because on the results, you're gonna build the treatment plan. which subsequently gives an abnormal results can then result in inability to trace the patients to whom the original specimen. For example, I know my patient's hemoglobin, these patients in our unit, like for 5 days. His hemoglobin is like in the range of 8, 7, 7.5, going 7, then jump to 8, in this range. Suddenly we find the hemoglobin for the patients 13. Or vice versa, we say that the range for the patients from 10, 10.5, 11, the second day coming to 10. Sometimes we are sending daily routine investigation. Then suddenly I found the hemoglobin for the patients 5 and no active bleeding, and so usually they are not building on these results. So the trend, it's not goes with this result. So maybe the physician ask kindly resend another CBC for the patients to make sure about the hemoglobin is correct and accurate for these patients, because mainly the vital signs is stable. No active bleeding, we can't see anything, patients is not complaining from things. So here we may say that the blood was for different patients. Maybe there is one of the process of extracting blood happened, and there is maybe something wrong happened in between. So we sent wrong sample for wrong patients, and we got results for these patients while it's for someone else. Patient received, also patient is given the wrong diagnosis. Yeah, we have to do patient identification well before open up with the patients. Sometimes the patients have only asthmatic, and he has something. It's not that big. Maybe we could say like pneumonia. He has a pneumonia, but it's maintained. Saturation is okay. But some of the physicians, they came along and they said to the patients, you have a cancer. We reviewed your CT scan, or we reviewed the result of biopsy came and we found you have a cancer. So that's better to do good patient identification and ask patients about their names before give them a wrong information about their health. You may traumatize them, making them feel bad. They will go with the psychological diseases, and maybe there is something happened to the patient. They will collapse, and they can't tolerate that or absorb the news. Patient receives inappropriate treatment. So yeah, I prepared this antibiotic. I went to this room because I know my patient or the patient I'm looking for always here, and getting to the room right bed, or the first bed on the right. Then I'm gonna give him the antibiotic, or I give him anticoagulant medication. Then I found myself in trouble. This wasn't the right patient, because maybe patient discharged a previous shift, and there is a new admission, or something. Maybe this is another patient coming from different room to this room, and I give him, because I didn't do the patient identification, I give him the wrong treatment, like incorrect blood components, or sometimes even the antibiotics or other medication. Patient is overexposed to radiation. Also, we did X-ray for wrong patient. I called the X-ray down, guys. I have a patient here in ICU or different units. they came along with the portable, then we did X-ray. Unfortunately, the X-ray supposed to be not for this patient, supposed to be for another patient. Also, wrong patient is brought to theater. We didn't do the patient identification. We get these patients and went down to the theater or operation room. We found ourselves in trouble, or we in guilt. We brought the different patients. So usually have to do good patient identification. Okay, we finished now the census and the introductions and general idea about what's going on the hospitals, about deaths, sentinel events, and many things that harm the patients. Now we have to introduce the 6 IPSG, the 6 goals of IPSG, the International Patient Safety. First of all, patient identification. This is the key for every procedures, everything in that single or tiny things in the hospital. Make sure to do everything. Even you want to talk to someone in the corridors, you have to ask about who are you. You have to know everything. So first of all, patient identification. Then we'll talk about effective communication. How do we deal with other colleagues? How do we deal with the patients? How do we do many things? Or how do I like with my colleagues? If I am supervisor, how do I talk to them? What's the channel of communication? Also, how are they to communicate with me? So thirdly, we will talk about high alert medication safety and how do we promote and enhance them in the hospital. Fourth thing, correct patient, correct site, correct procedure. Also, this is mainly about patients undergoing to the surgery. As we mentioned before, surgical errors. So we have mainly to focus on this goal to prevent the surgical errors. Prevent for risk. Also, we had talked about the patient for risk. That's a cause injury for the patient. So here in this goal, we will focus about how do we prevent for risk. The last goal, the sixth one is prevent healthcare associated infection. We talked about sepsis and about any infection that may got from the hospital. So patient identification, the first goal. Regardless of the healthcare settings, a patient's identity should be confirmed prior to commencement of any treatment, any therapy, or administration of medication. It's equally important to do so even in a patient's own home. So as we mentioned before, always identify your patients. And we have the process. How do we identify them? How do we put the ID band for the patients? Where we can put it? And what the documents we may rely on that for doing the ID band, keeping the ID band on their hands along their staying in the hospital. Principle to always ensure the correct identity of patients and before they undergo a procedure or receive therapy that requires positive patients identification. Staff are reminded that in adhering to the patient identification procedure that they should pay particular attention to other related policies, such as blood transfusion, medicines, management, and consent. Here in this point, they want to say every single thing you're gonna do, you have to do patient identification prior them. I want to give blood. I can't give blood without patient identification. I want to give medication. We can't give medication without doing patient identification. Getting consent. Everything, every single thing in the hospital, we have to do patient identification. Here we have some important definitions. We have to know them. So we may say these patients with similar name. So once I know what's the definition of patient with similar names, then I know what shall I do. Also, independent checking. Hey guys, you are not doing independent checking. If you are not know what do we mean by independent checking or second verifier, you may put yourself in trouble, whether with the admins or with the patient itself. So we have to know everything here, or we have to expose ourselves about these definitions. So first of all, we have to say, what do we mean by patient identification? Here they say it's the process wherein a patient is accurately identified, and identity is always confirmed to ensure patient safety and clinical accuracy. Once I do patient identification, it means I did a process that accurate identification, and I have make sure that this patient is the right patient. Also, independent checking. What do we mean by independent checking is that checking it twice by two members of healthcare workers, whether nurse and physician or two nurses. Usually you are doing this with high alert medication. This is one of the goals that we have to mainly focus about them later on. It's one of the goals. So usually in high alert medication, we have to do independent checking, whether high alert medication or blood transfusion. We have to do independent checking. So should be by two members, qualified members. They have to do the same. She or he do the patient, then I came after her or after him. Then I have to check the ID band. She checked the medication. Then I came. We have to check the order together, check the medication together, prepare together, everything. They say usually two hits better than one. Also, patient with similar names. Patient having one or more consecutive similar or identical names with another patient. Really, guys, this is one of the serious things I face them in the hospital. One of the physician came along from different units. For example, here we, because I'm working in ICU, so maybe the most of the example will be in ICU. Okay. We have the ICU nurses, we have the ICU physicians, we have like 20 patients in the unit. Usually we have like some patients, their names, Muhammad, Abdullah, these the common names. So maybe every day I face these issues. I have two patients with similar name. Abdullah. Some physicians, they are coming from outside of the unit. Assalamu alaikum. Hi, how are you? Where is Abdullah? Or which bed is for Abdullah? Or Abdullah, where is he staying? In which bed? Okay, this is. Some of them, they are rushed to answer you. If they came to me as a supervisor, okay, I told him, yeah, which Abdullah? Abdullah, could you give me the second name, family name, give me the patient's file number, what's the diagnosis? I have to get some details to guide him to the right patient. Then we can do the patient identification correctly bedside. But some of them, they rush to answer you. Where is Abdullah? He's in bed 7. While the Abdullah, he's in bed 10. So we have usually keep labeling the rooms, the patient files with the alert, or with labeling them with a similar name, signage. I have to put a label, big label, similar name. So if anyone from other healthcare practitioners came along looking for these patients, or he is looking for, as we mentioned, Abdullah, he found this patient, Abdullah, with high or with similar name. Then he said, this is might be not the patients I'm looking for. Then he has to double checking about the complete names to know this is the one he is looking for. So what are the purposes for patient identification? Why do we say it's important? First of all, to provide correct identification of all patients and all healthcare services within the organization. Secondly, to minimize the possibility of patient identification errors. So we may not do errors to the patient because we misidentify them. Thirdly, to always ensure patient safety by providing and ensuring mechanisms to verify correct patient identification. Fourth point is to provide a method of linking the patient to their medical records and treatment accurately. So once I got a report for this one, I have to put it in the right file. Nowadays, we may not using the files, the paper, the file based on papers. Maybe we use the system, but still we have to do the same. If even we are doing the system work or doing our work on the system, I have to carry out, or we have to provide the units with digital stuff like iPads or tablets or anything like portable computers. We have to do double checking. I have to compare the ID band across to the patient data on the system. Even we don't have the files or the papers, we can't omit this point. We have to do it. If we follow the paperless strategy, doing everything on the computer, we have to do this thing on the computers. If we are still follow the papers and doing on the files, we have to do the same. The fifth one is to develop a standardized procedure to be utilized in a patient care areas that increases staff awarenesses of patient names that are alike or similar in spelling or pronunciation. So we explained it, I think, in the previous point about similar name. So here the process, how do we do the patient's identification? Okay, I have some patients, they are coming from the emergency department, or they came to the hospital through the emergency department or through the emergency gate. They are getting to emergency, seen by physicians there, doing triaging. They direct them to green, yellow, or red area, depends on their situations. Then we have to attach the ID band there. Also, we have not all the patients that's admitted in the hospital, they are coming through emergency. No, they are coming through maybe OBDs, outpatients department, or through the D-surgery department. Yeah, so we have many approaches for the patients to be admitted in the hospital. So the important thing, whenever there is a point of entry to the hospital, we have to do patient's identification and put the ID bands at their hands. So, for example, an emergency department, complete name of patients according to the ID presented, medical record number. So we have to ask the relative to do the registrations or emergency registration form. They have to get to the reception. This is the name of the patients and this is the ID for him. Okay, blah, blah, blah. Then they print it out, the emergency sheet paper, or they admit it on the system and they give you the file number, or they will ask you to give the ID of the patients to the responsible guy inside. For example, the nurses, for the physicians. So usually you have to do comparing, starting with the ID, showing, validate this is the right patients. Or if it's an emergency or severe emergency, we have another strategies. We'll talk about it later in the slides. Also, we have to, but in outpatient, like in OBDs, in clinics, when patients came and the physician saw him and he decided to admit him. So how do we do identifying for the patients? With complete name of the patients. We have to ask them, what's your name? Even in ER, we have to ask them, what's your name? Then I have to compare the ID with their answers. Then I have to check the medical number, medical record number, the MRN, or we have to check the identification number. So I have two options, whether I have to do it with the MRN if he has it, or I have to double check it with the ID. So the patient's room number or location can't be used for identification. I can't ask my colleagues, hey, please do or give this medication, or kindly prepare the dressing trolley or anything, where just prepare it in bed 10. We can't go or work with these things. Now, I have to inform them, or we have to say, okay, kindly help me for this patient. The name is blah, 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 and this is file number. Okay. Or just get this the file, and this is the data for the patients. Then your colleague or by yourself will go and double checking to prevent the misidentification for the patients. So here we say complete name and medical record number must be used to verify a patient's identity prior to any procedures, but not limited to. Here we have important things. I highlighted them with red, but you may find something or many things in the hospital out of these things. They are also important. But here we are just give you an examples about the major things or the threatening things to the patients if we misidentify them. For example, administration of medications. We are giving antibiotics, high alert medications, and many things. Also, we'll talk about it later. Administration of blood and blood products. I have to give backed RBCs. I have to give FFB, fresh frozen plasma. I have to give platelets. Yeah, imagine if you are bringing some blood products and you enter to a wrong room and even like you are introducing yourself, well, this is me and I'm gonna give you a platelets. Then the patient got shocked. Why do you give me a platelets? Or why do you give me Bacter BCs or blood or anything? So we have to identify patients prior getting in, starting any procedures, giving blood, anything. Ever obtaining blood samples and other specimen for diagnosis analysis. I have to identify them well before getting a sample from them. Maybe I got maybe similar rooms, or we have many single rooms. I got to this room, I was thinking this is the right patients. And nowadays, most of the patients or comatose patients, they have the central line. So I will not bother myself to do patient identification. I was rushed to finish my duties and just I want to collect the samples and run away. Because you thought this is the right patients, while you get the samples from the different axes for different patients. So make sure about this is the right patient. Performing procedures. I'm doing, as you know, in the hospitals, there is some serious procedures that may done to the patient. So we have to identify them prior to transfer discharge of patients. Imagine you are in ICU and they decided you have two conscious patients look like they are okay. They don't need ICU and we are looking for beds for them. We booked one bed for a patient while the other one looked well, but we need to keep him. Maybe there is a pending procedure for him. Okay, I maybe discharge him by tomorrow or within 2 days, 3 days. Maybe he has a surgery next week, then I have to keep them. And I ask you, yeah, okay, kindly discharge the patients. Then you got these patients that's supposed to be doing the next week procedures, then you discharge him to the floor, to the general wards, or you discharge him home. Even in the general wards, okay, the physician saw you in the station. Hey, please, yeah, this patient, I did everything for him. Kindly just discharge him. Then you went to the wrong patient and you discharged him. Oh, this is a major error. Patient identity must be confirmed if the patient is below 18 years of age through the following relatives guardian. So imagine you have 18 years boy or 18 years old boy or girl. So we have to identify, how do we identify them like adults? No. Adults, we mentioned earlier, we have to identify them, asking them their names, checking their ID card or Iqama number or any kind of these things, or ask them about comparing the MRN, the medical registry number, with their names, with their answers. We have to do like this. This is for adult above 18 years old. But when we are doing the patient identification and we are going to do ID band for them, we have, if they are below 18 years old, we have to ask the husband. Okay. I'm not sure. Yeah, we have some under 18 years now and they have husband. But anyway, fathers, son, but what we wanted to say here, we have to ask one adult of their relatives, guardian. For example, oldest brother over 18 years. Yeah, he came with his brother. His brother is 22 years old, or her sister is 22 years old. So we have to ask her sister, what's her name? And yeah. Also, in case we don't have the above things here, the husband, father, son of paternal grandfather, oldest brother, these things, we don't have them. And and we found the patients with his friend. While his friend is over 18 years old, then we have to ask him, hey, what's the name of your friend? What's the relationship between of you? Maybe he's like cousin, and sometimes not. He said, yeah, just he's my friend. Then we have to go with the process of identification. Here also, we say ID wristband or ID band must be prepared and applied by the admitting nurse. For example, if in emergency department, the admitting nurse is the ER nurse. She's the one responsible to put the ID band for the patient. Also, if we are in OPD, we'll ask the assigned nurse in OPD. Yes, Badria, anything? Some of them, they Lubna Sufyani. Okay. Anyway, we have like an open discussion later on. If there is any questions or anything later on, kindly just write it down. Once we get to that point, we may know about it. Okay. So here we go also. We said all information needed in the wristband is written in a blue ink pen. So we have to write the data in blue ink. Sorry guys, is my voice is it clear? Okay, thank you so much. Thank you so much for replying. Thank you so much. I appreciate it. Okay, we gonna continue. Okay, ID wrist band must contain the following. So if I have an ID band, then what's the information that may is necessarily to be added there? We have to write the patient's complete name. We can't just write Muhammad Abdullah or something, you know, these common names here in Saudi Arabia. We have to mention there whether they are in the family name, or even non-Saudi. We may got similar names usually. So we have to go with the maximum I have to complete names. If they have three names at the ID, fourth names, better to mention all of them. Medical record number, nationality, age, gender, allergies. So if they have allergies, we have to use the red insert ID band. I mentioned before, we have to use, so we have to, three types of ID band. We will introduce them to you in the next slides. But one of them is ID band, the red insert ID band. This is for the patients who have allergies. So usually, or kindly make sure about applying these kind of stuff at your hospitals. Even the different color, but I have to differentiate between the patients who have allergies or the patient who doesn't have. So I have to two major things I have to make sure about implementing them in the hospital. One, an ID ban for the patient doesn't have allergies, and the one who has allergies. So also for patients aged from 0 to 6 years old, another ID ban or wristband must be applied to the mother. This is the green one. This is the green one. If I have a patient in pedia department or in the units that's getting or accepting patients below 6, like an example, in some general hospitals, it's not about in the children and maternity, they are accepting kids and they are accepting children at their hospital. So we have to make sure about provide a different ID band to the mother or the watcher. I can't give her the right one, the white one. Why? Because the other patients have the white one. I misidentify, or I thought I think this is the mother is the patient or one of the patients here in the department. Unfortunately, she's the watcher of a child. So we have to give her different color ID band. So once I see the green one on her hands, then I know this is a watcher. She is not a patient, or she is not even one of our colleagues, like doing, some of them, they working in administrative stuff. They are look like the watchers. What the things we differentiate between them? The watcher has green ID band on her hands, while our colleagues, they have their ID or hospital ID. So we have to make sure about these things. Sorry. So what's the kind of information that we have to write it on the band for the watcher? We mentioned for the patients, we have to do the patient complete name, MRN, nationality, age, gender, allergies. But for the watcher who's accompany a patient under 6 years old, I have to write the name of the patient she is accompanying him. Also, I have to write the file number for that patient. Then I have to write the name of mother or the watcher on the ID band itself. And also I have to mention what's the relationship of this mom or this father to the patient. They are guardians, legal guardians, or they are mother and father. Maybe they lost their parents, while the watcher is the uncle or cousins or brothers. I have to mention all the relationship of the watcher to the patients. Also, I have to keep a registry at the nursing station. I have a registry logbook. Okay. I have patients below 6. Then I have to write their names there and what's the name of the watcher. So later on, once I want to compare, I have to look at my registry. This is the patient's name and this is the watcher name. Then I have to look at her hands. Then I have to check. So usually we are providing a different color, but what I have here in my slides, it's up to you guys. If you want to, if you are happy about, but at least you have, this is the major things, the ID bands. Make sure about having them at your hospitals. But the hospital where I work in, we are doing these colors. Red because of allergies, white for all the patients, while the green The white for all the patient who doesn't have allergies, while the red one for the patients who have allergies. While the green one, as we mentioned before in the previous slides, for the watchers. So here we talked about it, registry book at nursing station. We talked about it in the previous, or we discussed it earlier. For example, in case of a change of watcher, this is an important point. In case of change of watcher, the nurse should orient the first watcher to introduce the next watcher for proper identification and register again in the registry book. So we have to do these things. For example, the main watcher is gonna leave to whom, okay? While the kids will be handled or will be watching by another guy or another girl. So the first one, she has to introduce, this is me. I am the mother, I am the father of this child, and I'm gonna leave, and this is my ID band, and I'm gonna leave the unit now to do some urgent stuff out of the hospital, but this is his sister or her sister or someone, or this is my sister, and she's the uncle of this guy or this child, and she will be the company. So we have to do another ID band, as we mentioned, the green one for her with the full data, the relationship to the patient name, and we have to also register her name in the logbook as well. So we have three types of patient identification. A white one, we said, like for all the patients who don't have any known allergies. Red one for the one who have or who has known allergies. Also the green one for the watchers. ID band must be worn. ID band must be worn by the patient at all time. It's not allowed to let them remove the ID band. Even they are kids, we have to ask the mom, please keep an eye on these patients on an ID. The band can't be removed totally. Even it's removed, we have to replace them. We have to replace them with a new one. Also, yeah, identification band must be attached to the patient's wrist using see-through plastic adhesive tape. So I have to put ID band is transparent. I can't see through. What's the data? Can't be hidden. If patients' limbs are not available, like some RTAs, maybe they lost their limbs or any of these things, or they got burned. You know, some of the burn patients, I want to use the hands to do dressing for them. So I can't put the ID band at their hands. So we have to put it in a visible area. For example, I have to put it on the chest itself. And I have to endorse to my colleagues. Because of this one, I can't implement or putting the ID bands at hands. So we stuck them or attach them to the chest area or any visible area. At least I have something there. And we have to do random check on them. You know, if it's not in the hand, it's possible to be loose. And we have to do everything before any procedures. We have to do. For all patients in outpatient department and other ambulatory services. Sorry guys, the slide, are the slides are visible to you? Okay, thanks for replying. You know, the technology, you can't rely on them all the time. Sometimes we are moving the icons from right to the left, then we may lose the things. Thanks. Yeah. So for all patients in outpatient department and other ambulatory services, patient identification must be done using the two identifiers. What do we mean by two identifiers? Maybe documents, we can call them documents, maybe patient's ID or MRN, if it's available. This is in OBDs, okay? Or ambulatory services, like in the day care surgery. This patient scheduled since 1 month to be visited here, so I have to double check with the patients whether he has the complete name as per ID presented or by the MRN. Identification band must be applied to OBD patients who are receiving chemotherapy. Even they are coming, you know, not all the patients, they are coming to staying in the hospital. No, they come to just to receive the treatment, and they go back to the homes. For example, patients on chemotherapy, they are coming to get their doses. Maybe we have some specialized clinics for the chemotherapy patients. So I have to apply. Even they are coming for a short period, maybe for 1 hour, 2 hours. But once they do any kind of procedures, I have to apply the ID band. Not giving, maybe, okay, some of people, maybe like in chemotherapy department or in any, not chemo, like hematology department, there is some patients on chemotherapy medication. Some of the patients, they are just coming to get ions, just to their hemoglobin is low, and just they want to correct it, just they want to get ions at this clinic. If no ID band to those patients, I may give the chemotherapy to the other one who's coming to receive the ions. So we have to be cautious. Even they are coming just for 1 hour, 2 hours, no, I have to do it. I have to apply the ID band. Also for the ISWEL, patients, they coming for ISWEL, which is, there is a stones there. They want to remove it through the ISWEL or through the extra corporeal shock waves. We have to apply the ID band. Patients, they are coming for dialysis, whether, yeah, conventional dialysis. You know, we have some centers are designed to outpatients. Once these patients came, I have to identify him well before doing the dialysis to him. And any procedures needing conscious sedation. Conscious sedation, like people, they are coming for bronchoscopy or any kind of EGDs. They need just all tapping. They want just to remove some fluids from their lungs, from the lungs cavity or from the abdomen. We need to give them conscious sedation. Before giving the conscious sedation to them, I have to put the ID band and get the consent and explaining everything to them. during extreme emergencies. We talked in the previous slides about how do we identify conscious patients or even unconscious, but they have relatives with them. There is an accident, the patient is comatose, but the relative with him, or the people, the one in an accident with him, they can identify them. So even in emergency situation, we say here, clinical care must take priority over attaching an ID band to the patients in life-threatening situation. During extreme emergencies, we may do the emergency stuff to the patients whenever there is a chance. Directly, we have to put the ID band to him, but we can't omit it. But we have to give that to rescue the patient. But later on, we have to put the ID band if they are in severe situation. Later on, after stabilization, through the families they are with them. For example, I have an RTA patient, or patients fall down in the street and brought to the emergency department by ambulance. We don't know patient is comatose, like maybe GCS3, GCS6, patients intubated, then brought from different hospitals. We can't identify him or her, or we can't identify them. What shall we do? What shall we do, guys? What shall we do? We can put paper. Okay. How do we name them, guys? How do we name them? Okay. Even we can't identify them. Yes, unknown. This is correct. Also, we may call them. It depends on the policy there at your hospital, but you have a policy. Have a policy for the unknown patients. The one can't be identified. We don't. They are they are comatose. They are intubated, and we don't know about any idea. What's their names, nationality? No iqama, no ID, nothing there with them. Even they have something in their pockets, we can't rely on them and admitting with these things now, unless there is someone accompany them and really they are saying this patient is, his name is like this, like this, like this, the name, father's name, family, but in case we have one of them, we have some policies at registry or at reception. You have to go to them to open a file for the patients. Hey guys, how are you? I have one patient, unknown patients. We can't. Okay, no problem. Okay, we will proceed the paper and to admit him under ER patients with random number. Now, for example, ER patients 126. It means 126 with temporary file number. If I have another patients coming also unknown, the system will give him or will give them different name, but on the same way. ER patient 190 with different file number. This is only temporary things until the patient has been identified by the family. Later on, within 2 days, the family came or the police came and they said, then they do the fingerprints for the patient. Also, if you have a patient, they come to your units admitting from the emergency department. Or if you are in emergency department and you got a patient unknown, you have to report them to the admins straight away. Then they will send to the police station. Then the policeman come to the hospital with their equipments, the digital stuff, and they have to identify the patients, whether by the fingerprint or the face picture, or maybe they have some data there. Then later on, the patients will be identified. Once we identify the patients, we have to change it. We have to change it. Going down to the reception or the admission office, ask them, hey guys, I have one patient under AR patient, and this is the file number for him, and this is the relative of the patient, and this is the ID of the patient. Kindly change them on the system under the correct names, then they will do. So here we say independent double checking of patients' identity by 2 members of the health care team must be done for procedures and or treatments done for the patient, which is include, but it's not limited to, as we mentioned before, independent double checking. It means with 2 qualified members must be done, especially for high alert medication administration. Guys, don't give any high alert medication without second verifier or without independent double checking. Don't give alone. There is this kind of medication, it has serious effects on the patients. Even the patients, you give the right things, patient they will develop side effects. Sometimes not because you give wrong medication, maybe the dose you give not adjustable by the physician. You have to get another one with you while you are giving. Even the blood, once I bring the blood to the units, I have to ask the physician. We have to start from the beginning. Okay, I have a patient for blood or any blood products, whether plasma or platelets. At the beginning, we have a strategies, or we have steps to implement them during giving this kind of products. Always we have to go with double checking from A to Z, from initiating the orders till the giving or to the last drip of blood. So at the beginning, I have to ask the physician. Once we send sample already, I know we send it by 2 qualified nurses or by 2 qualified healthcare practitioners. Maybe in OR, maybe the OR nurse or the circulating nurse, they extracting blood and for emergency, and they should be sent by 2. Once we set the sample or cross-matching by 2 nurses, once the result appeared, the physician will check it. Okay, then the nurse will check it. Okay, hemoglobin is low. Then the physician order a blood for the patient. Once the physician order the blood for the patients, I have to check the hemoglobin again, because I want to questioning myself. Maybe the hemoglobin is high. Maybe the order is wrong for these patients. Then I have to discuss it with the physician. Once I double check with the physician, oh, hemoglobin is low, then he will order. I want 1 packed RBCs, or I want 1 unit or 2 units for blood of blood to be given. Then I have to ask my colleagues to extract blood. Okay, we have to do cross matching. The first one we did CBC, okay, with 2 nurses. Then hemoglobin came low. Physician order a blood. I have to extract the blood or cross matching and blood grouping with the second nurse. Then I have to send it down to the blood bank. I have to double check with the blood bank technician. This is independent double checking again. Once the blood is ready, I have to go down to collect it. Then I have to double check with the blood bank technician. We have to check the patient names, MRN, we have to check it together. Then a blood group, the bag number, okay? I have to do everything with him. We have to double checking them. We have to check the blood. No bubbles there, no leak, nothing before collecting the blood from blood bank. Once I arrive to the units, I have to double check it again with the physician. Hey, doctor, I have a blood now, and shall we give? Then he has to check it with me. He write a clear order to me, even how many hours I'm gonna give, okay? Then I have to do it bedside with my colleagues, checking vital signs before giving the blood. Even before sending the samples, we have to make sure that vital signs is stable, not giving a blood with high temperature. Also, collection of blood from blood bank, verification, blood bank, obtaining blood samples, performing invasive procedure. As we mentioned before, I have one patient to remove some collections from the abdomen, from the lungs, any kind of invasive procedures should be needed double checking and need the consent, and yeah. And also we have qualified physicians or radiologists, qualified radiologists. We have to check their privilege. Have you heard about privilege, guys? Have you heard about it? Do you implement it at your hospitals? Privilege? Do you know what we mean by privilege? What we mean by privilege, guys? Yes, Samia. Okay. Yes, privileges, امتيازات, or for example, there is kind of a procedures. This physician can do ICT, chest tube insertion. The other physician can't be. Okay, depends on the experience, depends on the whether they are consultant, whether they are specialist, or just they are resident. I have to check their names before going the procedures to make sure the procedures 100% will be done from a qualified physician. So we have to, if you don't have the privilege at your hospitals, kindly work with the admins on that one. Every physician in the hospital, they have a list. Even I have 100 physicians at the hospitals. Everyone from them, he has a list under his name or her name, which kind of procedures she can do. Intubation, yes or no? ICT, tracheostomy bedside, insertion central line. Also, we'll go, yeah, because in the infection control strategies, there is something for insertion central line. Also, insertion IFC. We have to know, are they qualified to do these things? Otherwise, we'll cause infections and some errors for the patients. Yes, it's the responsibility of nurse on duty to remove the wristband when the patient is discharged. So we mentioned we can't remove the ID band during the whole staying of the patient at the hospital. When shall we remove it? If the patient has, they have an order to be discharged. I have to go down at the reception or the admission office, and we have to discharge them from the system itself. Then we have to discharge them physically. at the gate of the hospital, and I have to remove the ID band there. Maybe there is some of them, maybe they change their minds. Maybe some people they want to go DAMA, like discharge on their responsibilities against medical advice. Then later on, some of them they convince them. Now just stay for a couple of days to get some benefits. So better to remove the ID band after discharge them from the system and at the gate of exit. For patients with similar name, in case of death, the ID wristband must remain attached on the patient's body, are actively involved in the process of patient identification. Okay, even the patient died in the hospital, I have to keep it till I do the care for the patients, post mortuary care, or yeah, we have to do the care there. Then after I'm going to apply a name, their names there at the sheets. We cover the patients, okay, we cover the patients with white sheet, okay. Once it's completed, okay, I'm going to wrap it up. I have to remove the ID band, then I have to write the full name and the date of death, time, and the file number at the sheet itself. Also, for patients with the same or similar names, use complete full name, identity, okay, full names to identify the patients. MRN to avoid wrong patient identification. We explained this in the previous slides. We have to put signage there to notify other people's. This is similar names. We have another patients with same name. So please be careful. So what we call it, name alert precautions. This is the signage. Like I have patients high risk to fall, I have to put orange dot signage. I have patients on airborne precautions, I have to put the airborne precautions. So even I have two patients with same name, even first name, I have to put the signage there. Name alert precaution shall be initiated for patients with the same or similar names to promote safety by posting name alert tag on the head pad of the bed and name alert tag on the cover page of the patient file. So usually in the full risk, we do the orange dot. We have to keep it on the, if they are moderate or high risk, I have to keep orange dot at the head of the patients, at the head of the bed, okay? Like patients laying down, I have to put it at the back, at the head of the bed, okay? Attach it there. This is high risk. Also for similar name, I have to put name alert, precaution, name alert there, or similar name, okay? Above the head of the bed. Also, I have to attach it to the files. Okay, now we have done with the with patient identification. Do we have any questions? Both or one of them? Now, if you have both of patients, this is what you mean. If I have two Abdullah there in the unit, both of them I have to put, yes, I have to put, maybe this, I want this Abdullah while I found myself with another Abdullah. So both of them, they have both notification. I have to put here name alert or similar name at the file and inside the room, Also, the other room for the same name, I have to put it as well. Okay. Any other questions? For patient identification, just write it down. Okay, I mean. Okay, and now we finished the part of patient identification, or the first goal of patient identification. So we will be moved to the effective communication. This is the second goal in the IPSG. We have some strategies to improve effective communication. Effective communication. So the communication, maybe there is something called ineffective communication. We have usually implement some strategies to make this communication is effective. Also, we have, during the communication, we may get reporting critical results. We have to do it on a good way. Critical results, patients have critical results. It may threaten in their lives. I have to report it correctly on specific way to my colleagues to get an action or to correct these critical results or critical values. And we have the handover communication. I am a physician from 7 to 7 p.m. from 7 a.m. to 7 p.m. I have to endorse the patients to my colleagues who's on duty or on call, the one who's coming from 7 p.m. to 7 a.m. I have to implement a strategy to make sure that the full information has been delivered. We can't miss any, you know, in the hospital, the continuity of care is so important. So we have to good handover, even between nurses and between shifts. They have to do good handover. Because some procedures I didn't do in the morning shift, I have to endorse it properly to my colleagues through a systematic way, documented, and we'll go in depth about it later on. So what we mean by communication? Communication is the exchange and the flow of information. Can be communication if no another parties or another person, can't be. So should be between two people or between groups, one person and to another, or one person to a group, can be. Okay, you are disseminating or you are talking to another department. At least there is two parties in the communications, one sender and the other one is receiver. And there is some elements there, like here the definition says information exchange and flow of information and ideas from one person to another. It involves sender transmitting an idea, one thing. Second thing, what he's transmitting, idea, information. So second thing, there is one sender, then second, idea, information. Third, we have a receiver. We have a receiver. This is three elements in the communication. While the method of transmitting messages, this is the way. Also, we have the transmitting methods. Do I do it verbal or non-verbal? By gesture, with hands. If it's verbal, or sometimes non-verbal, may be written. I can send an emails to my colleagues. This is one of the non-verbal. Okay, we are using the words or gestures or hands. Okay, this is kind of communication, and you can't deliver the message. If I want to say no, I have to shake my hands. Then you did the communications. There is sender, you shake it to another person. There is receiver, and there is an idea or like common action between you guys. Then he got the message. If it's verbal, whether by telephone or face to face. Okay, this is one of the methods of transmitting messages. Okay, why do we mention these things? Maybe some of them, they are saying, oh yeah, I know about verbal and non-verbal communication. Why do I mention, or why do usually they are mentioned in the definitions? Because we have to provide the hospitals with the telephones, extension numbers, to make this communication as effective. Do you think if we are in hospital with 5 floors or 3 floors, even for 2 floors, do I need to go using stairs or elevators if I want to deliver messages? Just I want to go to him, meet him face to face? No, I have to find alternatives. There is something like not urgent. Okay, I will go later on and talk to him face to face. Or I will send an email to him. Or I will send a message to him. If you have like a group on the WhatsApp for the work, we have to send it through. But we have to provide telephone to fasten the delivery of information. For example, in the laboratory, they discover there is a critical value. There is calcium or the potassium for this patient is 2 or 3. I have to report it to the unit. I have to dial the number. I have the list of extension numbers there. Then I have to dial it. Hello, it's me. My name, blah, blah, blah. And this is my job number. Guys, you have a patient with this name, with this file number. Okay. Then I saw, yeah, WhatsApp. Then he said, the potassium for this patient is 3. 3 is critical value. Then I have to what? Repeat it back. There is a strategy. It's called repeat back or read it back. Okay. And then in some emergency situation, we will do repeat back. While in the like telephone reporting or someone over the phone, I have to read it back because I have time to write. Okay. I have to utilize a logbook for the critical values in the unit. For example, this is one of the examples. Also, we'll talk about it later on. I have a logbook there at the stations. Once I got critical values from the lab, I have to mention everything there, full details. I have to mention the patient's name, file number, type of result, this is what? Potassium, calcium, blood CS, hemoglobin, platelets, INR, anything that you feel it's will cause a harm for the patient, or maybe the potassium is high. We find potassium 6.5 or 7. I have to report this as a lab technician to the designated healthcare practitioners or designated nurse there at the unit. Then, if I was the lab technician, I have to get the one who's received, what their names. I reported to this guy or this girl, okay, with their names and their job numbers. If I receive it as a nurse, then I have to write the name of the one who's reported. We have to write the time they reported. Okay, what time reported? For example, now it's reported 10 4 a.m. Okay, I asked him, is the result on the system now? He told, yes, I already attached it on the system like 5 minutes ago. Then I have to check the system. Yes, the result is there, 10 a.m. Then I have to write 10 a.m. and the time of reporting 5 a.m. Then I have to inform the physician in the or the doctor in the unit. Hey, doctor, this patient with file number has a high potassium or low potassium. The result is like that. Then I have to write the name of the physician whom I reported to, okay, and the time, also the time seen, okay. For example, I reported to physician now, immediately, 5 a.m. Then I have to keep an eye, patient seen, there is an order to correct the potassium, whether it's low or high. Did they give anti-hyperkalemic correction, or if the patient's hypokalemia, did they give correction? They add give KCl to the patient. Did they give? I have to keep monitoring. Later on, if there is delay, I have to go back to the physician. Hey, you didn't correct. In case you feel there is a harm, okay, you have to escalate the issue. You have to write an OVA. Then we have to correct it and to prevent these things not happening in the future. This is kind of also we have to we have something called vertical communication. Vertical communication. If they're supposed to order it, some laboratory, the police, if there is critical reports to doctor, order it. Could you clarify, Abdullah, about this point? I didn't get your message. Some laboratory policies. Usually we have at every hospital, there is some critical values. I will show it later in the slides, already attached here, just for an example, for some critical values, but it depends on the hospital where some of them they are considering 3 is normal, but some of them they are saying no, 3 is not normal, 3.5 and above, for example, for the potassium is normal. So all of you guys have to work on the same way. We have a sheet there in the units and in the laboratory. Even for every critical values, or we say in our hospital, this item once to get to this level, it's critical. You have to report it. The lab technician has to follow, the unit nurse has to follow, the physician also, they have to follow. We have vertical communication. What we mean vertical communication? Vertical communication, whether it's coming from up to down or from down to up. This is the vertical. And there is something horizontal communication on the same level, from right to left, or just like on the horizontal line. It's the opposite of vertical communication. Vertical communication, always from up to down or down to up. If it's occurs within the level of authority, like in the hierarchy, if the medical director wants to disseminate a message to the units department or the department heads or the managers in the departments who's belong under him in the hierarchy, we call it downward communication. Okay, this is one of the if the message will go from down to up, we call it upward communication. For example, from the staff to the supervisor, or from the team, the physician, from the residents to the head of department. We call it upward. Okay. we'll move to the next. Yeah, I got you, Abdullah. Okay. We'll move to the next slide. So we have two kinds of, we mentioned before, like vertical communication, downward communication, and upward. Downward communication occurs when information flows from superior to subordinates, from the manager, from the boss to the staff, or to their colleagues, but from the manager, from the supervisor. Because we follow the hierarchy from up to down, in the hierarchy we call it downward communication. If it goes from down to up, from the staff to the supervisor, to the manager, then in the hierarchy, then up to the hospital director, we call it upward communication, escalating. Okay, in case there is, usually it's like usually in the issue. You want to escalate, you are a staff, you have to escalate it up. It means upward communication. While the downward communication usually like giving instructions, disseminate messages. There is a new report, I have to share it with the colleagues. Superiors and send information, orders, instructions, decision and instructions. Guys, we decided to work 12 hours duty. Then they have to follow. This is instruction. This is my decision, or this is the hospital decisions. Then the subordinates will receive the messages. Upward communication occurs when information flows from subordinates to superiors. The opposite, you see, the opposite in the organization hierarchy. While the horizontal communication flows across the same level of organizational structure. For example, I'm working in GS or general surgery wards. I want to communicate with the medical wards. We are on the same level. So this is horizontal communication. Or sometimes I am in the nursing field. I want to communicate with the pharmacy. We are on the same level. I want to communicate with the laboratory. We are on the same level. Okay. This is, we call it, or I am here in this hospital. I want to communicate with other hospital. I am in King Fahd Hospital. I want to communicate it with the Saudi Germany hospital. Or I want to communicate it with King Faisal Specialist Hospital. This kind of, from one institution to another, also we call it horizontal communication. Why do I communicate with other? Sometimes I don't have the service to give it to the patients. I have to send fax. This kind of communication between hospital, we call it horizontal communication. Communication system. What do we mean by communication system? Communication system, any devices or any networks. Sorry. Communication system is a collection of individual communications network, transmission systems, relay stations used to transmit information. So I have I mentioned some list here, like website, like HIS, Hospital Information System. This kind, it's communication system. Emails, anything you are doing, that shows the communication. This is communication system. Some of them, they are reporting, oh, we have issues at communication system. If you have communication system issues, you have to fix it or find alternatives. For example, I don't have emails, or we don't have fax. I have to use the emails. We don't have fax and emails. I have to use the WhatsApp. But but I have to make sure the WhatsApp application is approved by your hospital as a standardized communication. Some of the hospital they are saying not, but the hospital where I work, the WhatsApp is one of the things we can take decision on them, or just to disseminate the message fast and fast till I get the official report through the emails. Also, yes, here they say assign a standard language to be used in any communication at any institutions, such as Arabic and English, or just English, or just Arabic. It depends on the policy there at your hospital. But once we say the English is the standard language, everybody in the institution has to follow. No Arabic at all in the institution. We have to follow English. Once we say both of them are acceptable, we have to use them both, only Arabic and English. But recently, the English is the most wide used in the hospitals because we have different nationalities, like non-Arabic speaker. Non-Arabic speaker. We have Indians, we have some people from Pakistan, we have different countries. They use the English, or from Africa they don't speak Arabic, from Europe they don't speak Arabic. So we have to keep the English as the standard language, and we have to follow it whether we speak it or document it. We have to document in English. And we have to orient this one, or inform all the employees in this regards, to prevent the harassments or humiliating other peoples. We are not allowed to speak in our dialogue or in our languages while the English is the approved one. For example, we are Arabs and there is one Indians. We can't discuss in Arabic and omit them. And the vice versa. If there is some Indians, they talk in their language sense and I can't understand them, I have to ask them, kindly guys speak in English to share you the information, or just to get an idea about what are you going to do and what's the management for the patients, to be on the same level. English, all of us will speak English and not get the other to feel bad. So here is some example for the communications. Committee meetings, monthly, maybe monthly meeting, or departmental meetings. Committee meetings, like there is many committee meetings at the hospital, like for infection control. From the nursing director, the hospital director or medical director, the director of infection control, some people from the labs, because the infection. Then this is kind of committee meetings. While if it's departmental meetings, we are in like in ICUs, we have monthly meeting. We have to sit together. We have some agendas to be discussed. This is kind of meeting, implement the communication. Then we have to, if there is some KPIs, we have to discuss it. We have to sit down on one table. Then we have to discuss it together. Written letter, memorandum, using fax. Some fax nowadays they are using between both two hospitals. Still we are using fax, while the emails should be done inside the hospital, or just escalating till the main or the headquarter office. Minute of meeting, you can do it with your staff. If you are supervisor, you have to assign one day monthly, or every 2 months we have a topic to communicate, or just to discuss about the unit. What's the agenda, what I want, what I noticed, guys, and we have some deviation at this point, so we have to work on them. Also, overhead paging. If I don't have the extension number or the phone number for one physician, and I have an urgent case, I have to do overhead paging, call the operator. I have to usually we dial 0, then I call them. Kindly, could you do overhead paging for the GS-ROD, surgical ROD, or the medical ROD? Yeah, depends on the service you are looking, or also during the CPR. Hey guys, could you do the code blue for me? If you are implementing go with the codes, like in the cardiac arrest, we usually announce the code blue. Okay, we have to call to call the operator to paging. Also, if you are using the hospital information system, nowadays most or 90% of hospital, they are using the hospital information system. However, still hospitals, they are still working with the papers. However, hospital information system is kind of communication system. I have to document there, I have to request there. My colleagues in other departments will receive the message, whether it's a request or just some data and endorsing about one patient. Bulletin boards. Bulletin boards, this is the board where we put it the memo or memorandum attached there at the bulletin boards, or some KPIs for this month. I have to attach it there. So everybody getting to the office or to the unit, they will have a look. Or I have a seminar, or I have a conference. I want to announce about the conference, or I have a course coming in shortly in coming weeks. I have to announce it there in bulletin boards. So enable all the staff to see them. Periodic reports, as I mentioned, KPIs. If I have KPIs for the units, infection, the compliance to hand washing, for example, CLABSI rate, central line bloodstream infection rate in the unit, how many CLABSI we got last month. All these, it's call it periodic reports. It's coming monthly, like or in the first quarter of the year, second quarter, third quarter. This is the periodic, at least certain amount of time. Also website, we have to post many things there at the website. As I mentioned, anything like I attach it in bulletin boards, I may do it as well in the website. The same purpose, but different techniques. Harassing words are not allowed to be used in any of communication. So we encouraging the staff always, guys, be professional. Don't go deep in the talk. Some people, they got you wrong. Better be professional with your colleagues. Don't joke with them too much. Only when you know people, because you can't know all the personalities of people. So better keep it professional. And yeah, just respect, smile at their faces. This kind is acceptable, while harassing words, heavy jokes, and this kind of stuff, it's not recommended at the work environment. And using the same languages addressed to that family is not allowed either. So we mentioned if it's English, we have to follow the English. We can't talk in Arabic, while others, they are not understanding Arabic. When the message and or feedback are that real important, a direct personal contact must be made to the recipient. As we mentioned before, if I have a critical value, I have to report it immediately when the message are the real important. Anything will touch the patient is really important. or real threatening to the patients. It's serious. I have to report it immediately. And I can't just dial the units here, blah, 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 and I call them, hey guys, you have to... No. I have asked who's receiving the message. Who are you? May I speak to the charge nurse? May I speak to the ICU physician? May I speak to the physician who ordered the lab to convey the message or just deliver the message correctly to the right person? Why do we give it to the right person? Because I'm looking for a solution. Not just I want to report. No, we have to correct it. We have to correct it. It's our responsibilities, especially when the patient's in the hospital. Vital communications must be documented in a memo or letter duly signed. For example, vital communication must be documented in memo or letter duly signed. Vital communications, some of some nurses, they want to open narcotic. This is when they communicate with you to open narcotic, we have to document it in a registry and or letter duly signed, okay? On memo or letter duly signed, and should be signed by two. Since time is of the essence, or just sometimes you want to deliver a letter, it's important letter, okay? I have to, this is maybe for the administrative stuff, I have to sign there and I have to ask him to sign as he received, okay? Since time is of the essence, the fastest mode of transmission is used in sending the message, direct contact or telephone call. Okay, we have, this is two of the fastest mode of transmission. I have to meet him face to face. This is direct contact or telephone call. Also, we have to use the email. Before, like long time, every department has a fax. We have to use the fax. Nowadays, not. The fax only provided to some certain offices, usually at the fax department, who's those communicating with other hospitals. Maybe, yes, but usually even they use fax, but also they use the system as well. Okay, as part of cost cutting, so we need to reducing the cost. We use the fax machine, or before long time, they give it with the messengers. Some envelope, they send it through the post office, and this kind of stuff. It's complicated and it's costing. You're gonna pay to the messengers, you're gonna pay to the post office. Yeah, many budgets needs to implement this. But nowadays we are using the email. But once you use the email, you have to follow the chain of commands. For example, if I'm a nurse, okay, I can't report directly to the nursing director. You have to follow the chain of command. You have to report it to your supervisor, immediate supervisor. If he can't solve it and you feel it's gonna be complicated, ask him. If you can't solve it, kindly escalate it. Kindly send it to the other supervisor till the message gets to the nursing director. Also, if you are working in a medical department, I have one issue regarding myification. This is one of the syndromes these days, the myifications, and most of the people, they got fight about them. So I have to go on that, or maybe within 2 months. I have to go on, for example, August or October. I requested my immediate supervisor, he couldn't solve it to me. Or just you report it to the head of department. Then he can't solve it, ask him to escalate it till get to the medical director or hospital director. But you can't jump directly to the medical director now. You have to implement the professionalisms and chain of commerce. There is some general laws here we have to follow if we have or just during the communication. In case you have a ringing telephone, they say must be answered within 2 to 3 rings. Kindly don't ignore the calling, because some people, they report a critical or vital information to you, you have to receive it. Never indulge the tendency for sarcasm in verbal or written communications. Yeah, as we mentioned before, be professional with your colleagues. Introduce yourself, deliver your message in a good way, in a good manner, and they have also, and be open up for discussion. If they want to ask you, it's not too long, just short questions, just to get an idea. If you think it's going to be long discussion, better to arrange a meeting. Hey guys, I think it's gonna be too long, so better to sit together and talk. At least, yeah, within the respect way. Whenever answering telephone calls, follow the protocol and route the same to the concerned person and requested by the caller. Hey, it's me from that department, from the X department. May I speak to the head of your department? This kind. But you have to introduce yourself. Don't call them. Usually what we notice, they call you, then they say, who are you? Instead of answer them, I said, you guys call me. Who are you? Then, yeah, you have to introduce yourself. Okay, then ask about who did answer you. Then send your message. Refrain from using facility telephone for personal calls. So if I don't have balance at my phone, it's not allowed to me to use the hospital telephone. I have to dial 050 blah, then I have to call for personal calls, not allowed. Email not concerning everyone group should not be sent to everyone, but must be sent to the concerned addresses only. What we mean by this message, if you have an issues, just send it to the immediate supervisor. No need to make CC for all people. Okay, no need. This is only your concern, and you are looking for the concerned addresses only. Communication system. In the facility, it's important to provide a 24-hour communication system. Why do we? Some of the staff, they have emergency situation. They can't come to the duty. We have to notify them. If you have an emergency, you have to call this number and you have to report it, or just you have to report it to the charge. Okay, to the charge, and people, they have to know who's in duty. At the beginning of the month or by the end of this month, I'm gonna disseminate the next month's schedule. All the communication contacts supposed to be there, and the names with time, So in case I have emergency situation, I have to report it, even in the evening or night shifts. A designated telephone line is available for emergency contact in the event of disaster. So every unit has to put a telephone for their departments, and the extension number should be disseminated to all the departments. The ER can call the ICU. The ICU can call the medical wards. The medical wards can call ICU. Everybody knows the other extension numbers, and we have to keep a directory there at the nursing stations or in the offices in case we have emergency or I want to communicate with other departments because of this or that. We have to call them on their extension number. A two-way radio communication is available for ambulances and other official vehicles. The two-way radio, this is the one they are using at ambulance. Ambulance, they are using to report to the, for example, command center. I got a patient's RTA with GCS like this. They are calling like, they are using the two-way radio communication. Where I will transfer the patients. Then they got the message or the decision or the direction from the command center. Kindly just direct him to this hospital or that hospital. Depends on the nearest one to you. Also, you're gonna call, I have one to transfer out of the hospital. Then they call the command center. The command center will call the hospital. This kind of communication, we call it a two-way radio communication. Okay, facility communication functions will include, okay, audible overhead paging system, we mentioned before. Every hospital has this one, the audible overhead paging system. I have CPR, I have disaster, I have fire in the hospital. How do we announce? How do we announce to all people to use the exit door in case you have a fire? You must have audible overhead paging system. You have to dial 0 or the assigned number to you at your hospital, or some of them they are using 5555 2222. Depends on the number at your hospital, but you have a system for this one. Then the announcements will come. Code blue, code red, code yellow, trauma team, like this kind, or just stroke team. This kind of paging, it's vital in the units and will help the patients. At the end, will help the patients, will help the staff if you have the overhead paging system. Even if you are in a small hospital, you can't omit it. You can't omit it. They are saying, no, we are a small hospital and we can like have telephones. But the over paging is one of the effective and fastest system. We have to make sure we have it. Also, we have a policy for it. For example, we have to do a memo or just disseminate a message to all people. Guys, if you have CPR or patient arrested at your unit, you have to dial 5555. Okay, maybe there is a special extension number for over paging or for the operators. Once he hear or she hears this phone is ringing, she knows that there is code blue. There is one patient is arrested. I have to over paging. Also, we have wireless phone for physicians and key personnel telephones. This is some of them, they call it bleep. Okay. Some hospitals still they are using every physicians, every head of departments, they have their own plebs. And instead of calling there on their cell phones, I have to call them on the plebe. Or some physicians who's on call, they have their own plebs for the on-call physician. For example, I want to the GS or general surgery on call to see these patients. I have to call on their plebs, or the medical, or endocrine. What is the specialist I'm looking to? I have to call there on the plebs. Doctor offices, clinics, extension numbers, and wireless phones and mobile must be available in every nurse station. As we mentioned before, you must have a directory or one file. It has all the extension numbers there. Okay? All communications with vital information must be documented. As we mentioned before, if we have critical value, we have a logbook or registry at the unit. Once I receive, I have to document everything. Date, time, name, patients, file number. To whom do I report it? To which the name of the physician? What's the name of technician who's reported? What's the time they put the result on the system? What time did they report it to me? What's the time patient seen by physician? All this should be documented. In case there is investigation later on, this kind of documentation will protect you and will stand by your side. Okay? Don't ignore it. Really, it's vital. And you know, during the medical errors, sentinel events, they will go to this documentation. They will check everything. Where is the lacking? Who did the something wrong? Once you documented well, really it's gonna help you. Also for the lab technicians, if he's reported the critical value, he has or she has to document every single things. I reported to to this nurse name and this employee number. In case they blame her later or someone investigated, or when OVA came, occurrence variance report, or yeah, OVR, some of them they call it OVR. Okay, she or they will defend on their behalf. Now, yes, I saw the result and I reported to this guy. Even the nurse, if they investigated the nurse or the one who received the call, yes, I received and I know it's a critical value and I report to this physician. Then the blame will go to the physician. And if there is penalty will come, there is some punishment, cutting salary, these kind of punishments and stop working, it will come to the only the person who did the wrong things if we have good and proper documentation. Why do we do these things? To support the second goal, to improve effective communications. And nowadays, most of the hospitals in the Saudi Arabia or in other regions, they are relying on the accreditations of the some company like the CPI standards. And one of the things they are looking for, do this hospital has effective communication? Do they have effective communication system? They are checking your data just to validate. And if you are looking for the accreditations, it shows that this hospital is applying the quality of care and quality standards. So you will get these kind of accreditations. If you get the accreditation, what does it mean? Whether SIBAHI or GCI or depends on the country you work in, depends on the hospital you work in. But most of the hospital, they are looking for some named or well-known accreditation company or accreditation standards or certificate. Once we get this accreditation, you will show that to the customers, to the patients, to the community, we are qualified. We are qualified. We are a good hospital, or we are a hospital who give a good and good quality. Then yes, then you will get so if you are you will improve your reputations. What's the things nowadays they are saying this hospital is better than this. No, I will not go to this hospital. I will go to that hospital because they got the accreditation, because they are implementing the quality of care. They have good services. So the medical errors may not happen always because they have good standards, good system. So I will go that once the many patients will go to one hospital, even for the income for that hospital will be increased. And if the income increased in that hospital, the staff will get benefits. So by the end of the year, once we see the income or the budget reaching to this amount, the managers will say, yes, that the staff deserve bonuses. We have to increase to give them some percent, okay? Some percent because we got good income this year. General rules for communicating by letter, memorandum, internal and external, as sender or originator. We have here some rules. If I am a sender, I have specific rules I have to do it. If I am a receiver, there is some rules I have also to do it or follow it. For example, or just we'll start with the number one, plan the communication based on subject to be communicated. Accurate and convincing facts of the message to the receiver, recipient, aims, objective of the message, and best time to send the message. What do we mean by this point? Sometimes we notice some emails, they are coming to us with no topics, no title there. It's losing its professionalism, also the importance. If you want to give that feeling your message is important, whether to your subordinates or to the superior or immediate supervisor, start with the topic. For example, if I have an issue in the unit, I want to report it to my supervisor, I have to put a nice and specific and not that long, but specific, and deliver the message. What are you going to describe inside the message? So we have to put a topic for the message or to the email. Some of emails coming to us with no topic title. I think this is not good, okay? Sometimes some of them they are ignoring, or in case later on I want to scroll it or review it, I can't find them because I can't remember. Better to address your email with a good title. Also, we have to describe the issue as it is. Be specific there. don't go too long or don't go too short. Usually use the title, okay, when you are sending to whom it may concern, to medical director or doctor blah blah blah, medical director, with respect, dear, you have to start your message with the suitable title for the one who's receiving. Then go to the body of your message. Write it specifically and describe it well, not too short, not too long. Okay? Also, just write your names down. If this message it's belong to you because of something related to you, better to mention your employee number down your name, or just ID. Because I am a supervisor and you reported to me an issue, I have to work on them by using your employee number. If you have an issue in the system, I will use your employee number, or I want to double check with the ID or Iqama number. You have to write it down with full name. We are not assuming to know all people. So better to end up your message with your name, title, ID number, and employee number. Also here, include the subject in form letter, message construct, select words, yes. Select words, this is so important, phrases and sentences that convey the meaning of the message. Consider the recipient's language vocabulary. So don't use Arabic and the one you are sending an email to them, the English speaker, and vice versa. Okay. Are we good so far, guys? Everything is clear to you? Thanks, Selena. Thank you so much. Zainab, Hanan, Harzam, Abir. Okay, thank you so much. We'll carry on. Anyway, we'll continue till now it's almost 11. We'll continue till 1 more hour at 12. We're gonna open a discussion like to 12:30, then we're gonna have a break from 12:30 to 1 p.m. I know you're I was in a situation like you before. Thanks Ghada, thanks Masha'il, Hatun, Huda, thank you so much, appreciate it. So kindly select the proper words and the phrases when you are sending a messages to your colleagues. Don't go out of the topic and don't mention something you may regret it later. Try to select the suitable time when you are writing an email. Don't write it when you are, they are saying usual, don't give the decision when you are so happy, or you are when you are so sad. Because really you will it will come against you. Okay. Lina, we'll finish at 12. Still we have 2 more. Okay, we'll finish at 12. Then we're gonna have 30 minutes break. Then we'll come back at 1 p.m. Okay, to continue 2 or 3 more hours. But we hope it's going well. But once you get your break, I think we'll be fine. Okay, so we repeat it again, like from 12 to 12:30, we're gonna open discussion. If anything we mentioned wasn't clear, or you want to just double check about certain information, from 12:30 to 1 p.m. we're gonna have break for prayer and We may call it lunch break or coffee break, up to you guys. 1 p.m. we'll be back to continue our lectures. So determine the best method of transmission, appropriate timing when the message can be sent and received, and the environment in which the message would receive. Determine the best method of transmission. Yes, we have, like, I have urgent things now. I can't come to the duty. Do you think I will use the email? No, I have to use the call. So select the best method of transmission. For example, if I have like long topic and not urgent, do you think I will call the supervisor, hey, I want to meet you, or just you will open up with them over the phones? No. Set up a meeting with them and go and sit with them and discuss it to show your professionalism. Also, we have to select appropriate timing. Like you want applications, okay? And you want a vacation, then you starting a message to your supervisor at late night. This is not good timing. Or early morning, 5 a.m. I have, hey, Assalamu alaikum, I want a vacation like next month or within. Okay, we can answer you later on, but better to select the good timing. Also, like going to meet the director early morning. They didn't receive their units and they didn't. Now, just set up a meeting with them. Better to arrange before going. They have their own agendas. Maybe they have a meeting. You can't go like this. Now, appropriate timing with arrangement. Also, appropriate timing when the message can be sent and received. Also, even like appropriate timing with the patients. You can't open up with serious things with nobody around, like no families, no social worker. Now, select the good environment. And don't open up when they are standing with bad news. They may fall down, they will collapse. You have to give them, like, you have to know how to open or breaking the bad news. Perceive the best message is clear and understandable to the receiver, relying on your experience, knowledge, and relationship with the receiver. So I have to use my skills, my experience when I'm delivering the message, and I have to know who's the one is receiving the message. Even you are dealing with the cleaners, and you can't go beyond their knowledge. Just respect their levels and just convey the message you want to deliver. Also, if they are from different, okay, I am a physician, I want to report it to the pharmacist. Then I go with the details for the patients at the level that the pharmacist can understand it. No, you can't go beyond till they give you the message, they understand you. This is what we talk about. We will talk about it when we go to the sender, the receiver. So the message receiver, which we call it recipient. Decode. The process here, we call it decoding. While for the sender, we call it encoding. Here, decoding, like interpreting. We are interpret the message, act accordingly when the message is clearly understood. So I have to give them notice. The one who sent the message, so if you are unclear about the meaning, so I got you. When they call you, I have these things and these patients. Okay, yes, I got you. This is kind of messages that give the sender, you got their message. If you are unclear about the meaning of the message, seek a clarification from the messenger. What do you mean by this point? Do you mean this or that? So get a clarification. Don't act you know, but actually you don't know. It may come negative on you or on the patients as well. Provide feedback when necessary to continue the flow and exchange of information between you and the sender. Sorry. So provide when necessary to continue. So if you need to clarify about any certain points, you have to double check with them or ask them more details. For example, if I'm working in the OR and I have one patient there in the units, general wards for OR, I have to call them. Is the patient ready for OR? They will say yes, after you give them their names and the name of the patients and the MRN. Is the patient ready for OR? They said yes. Do you think that's enough? I don't think so. I have to ask them, does the patient has a consent? Does the patient have, or does the patient's MBO? Or is the patient MBO? Does the patient seen by the anesthesiologist? Does he has an anesthesia consent? Okay. You have to ask many questions to prevent what did we say when we get to the point of surgery. We have to talk in details about them. Then provide feedback when necessary to continue the flow and exchange of information between you and the sender. Okay, this is repetitive. Okay. We have also in two-way communication. That in two-way communication, the sender transmits message to another person who is the receiver. When the receiver gets the message, they send back a response acknowledging the message was received. This is what we call it during the ambulances. When they call the command center, this is the two-way communication. Once you receive the message, you have to say, got you, or copy. These kind of communications should be, especially in the two-way communication, you may lose the signals. So we have to make sure to do this strategy, got you, or copy. Yes, I receive it. Yes, yeah. So vertical communication, we talked about them. We defined them before: downward communication and upward communication. But here is some examples to the downward communication and upward communication. What we call both of them is vertical, from up to down or down to up. Here we say facility medical director or head of departments must communicate directly with the immediate supervisors, discuss broader concern and guiding principles, such as the facility's vision, mission, and strategic goals. So the medical director, they have open up or just discuss these things. If I have a vision and mission and strategic goals for my institution or hospital, I have to disseminate it and discuss it with the subordinates, with the staff. I have to discuss it with them. Guys, I have a vision like this. Our vision is like this. Our mission is like this. And the goals, the strategic goals, or the values is these things. We have to work on them. This is our vision and mission. Then we call it downward communication. Also, the immediate supervisor must communicate with their direct reports or to their staff. If I have a message from the immediate supervisor to me, or if I am the immediate supervisor, I send it to the staff who's under my names, okay? Or I call it also downward communication. They may communicate downward by sending employees emails, messages, presiding at department meetings, giving employees policy manuals, posting notices in bulletin boards and letters. If we did these things from the up to down, we call it downward communication. Whatever the strategy or the system or the methods you are used, both of them, downward communication is coming from the superiors to subordinates, from up to down, whether through emails, meetings, posting, anything. While the upward communication is coming from the staff, from down to up, from the down of the hierarchy to the up of hierarchy. If I am a staff and I reported to my immediate supervisor, I call it upward communication. Usually these kind of communications to report issue or giving suggestions, or just they complaining about something, or just they want deliver their feelings, complaints, make use of superiors through, or maybe the recommendations. Like I am a staff and I notice these things in the unit, I have to report to my immediate supervisor for correction plan. If I notice something wrong in the units, I have to report it. Okay. Departmental staff meetings are held on regular basis and minutes are documented. It's so important if you are supervisor and you are doing meeting with your colleagues, you have to ask them by the end of the meeting to give their signatures. It's good for you for documentation, to save your work. Also, it's evidence and documentation. All the staff got your messages. For next time, if you discuss anything with them, they may not say, I have no idea, or I don't know. Horizontal communication, as we mentioned before, if I have one patient here in this hospital and I don't have the service or the facility to serve him, I have to send a fax to another hospital to get a help from them. I have to email them, hey guys, I have one patient here, he's going to a surgery, a neurosurgery, GS, anything of surgery, or any kind of procedures need another facilities, but you don't have it. You have to mention the email in regards to these patients, or because of, as a result of these things not available in our hospital, and they have these patients, then they will give you the reply. If you do these communications or this kind of communication, we call it horizontal communication. Later on, like with regards to referrals or other administrative issues, or even you are sending some messages. As we mentioned before, if I have a non-patients, the hospital should communicate with the police station. This kind of communication, we call it horizontal communication, as here in the second unit. So verbal and telephone order, critical values. We have here some important definitions. First of all, authorized practitioners, telephone order, and verbal order. Okay? We have to know each one of these because later on, I'm gonna build my decision, my documentation on those things. Authorized practitioners. Who's authorized practitioner? I can't report any things to anybody. Just anyone pick up the phones, then I have to give them straight away the information I want. Now, I have to ask them, introduce yourself, ask them who are they. Like here we call them, includes physicians and advanced practice professionals. Maybe the one answered the phone is the watcher for the patients. Then I straight away I give them the message. You give it to the wrong person. Acting within the scope of their privilege or job description. Then what we mean by telephone order? Specific orders for the specific patients giving over the telephone to unauthorized staff, like nurse practitioner or physician or physician assistant or anybody, to be carried out before the orders are countersigned by the ordering practitioners. So I have one patient now. He developed hypoglycemia. What shall I do? I discovered this one. Then immediately, like maybe the blood glucose is maybe 70 or 60. As we know, if we didn't help the patients or rescue the patients in this condition, he will collapse. So I have to call immediately the one on call if no physicians are around you. If you are in general wards and nobody around you, you have to report it immediately. This is one of the critical values. Hey, doctor, I have one patient here, with this kind of informations. Then he's gonna give you the order over the phone. If the order given over the phones, we call it telephone order. I have to document it down and I have to get a witness, like my colleague. If I am a nurse and I have to ask my other colleagues to come beside me, we have to hear the order together and we have to write it down. Telephone order was received from this physician, name, job number. Then we have to write the full data we received. Then he ordered to give D50, dextrose 50% to these patients. Later on, once he comes to the unit, he has to write it down and he has to sign on the order. But because of this emergency situation, we have to accept only for certain emergency situation, we have to accept the telephone order. Having said that, you have to rely on the policy at your hospitals. Some of the hospitals, don't have the telephone order. Okay? Just follow the one, but also, and some of them, they have telephone order, but only for certain situations they have it, not for all the certain situations. This is the telephone order. Why the verbal order? Specific orders for a specific patients given verbally to an authorized staff to be carried out before the orders are countersigned by the ordering practitioners. What's the difference? Telephone order, the physician is not around. He is maybe outside of the hospital, or maybe he's seeing an emergency case in ER and you have an emergency at your unit. He will give you order over the phone. But the verbal order now, you are in the emergency situation, for example, in CPR, during CPR. If the physician give you an order, give adrenaline, give atropine, prepare the DC shock. All of these things, we call it verbal order. There is verbal, but guys, here I have a message like the internet is unstable. I'm not sure. Clear? Is it clear? Kindly, if You have an issue at the voice. Kindly just write it down in the chat. Everything, yeah, clear. Okay, thanks, Mashal. So anything done during the CPR, we call it verbal order. After the patient is stabilized, or the scenario is finished, maybe the patient stabilized, or maybe patient died, the physicians has to come and write everything during that scenario. How many adrenals was given? How many DC shock? How many CPR done? Okay. Also depends on the policy of your hospital. There is verbal order. Okay, patient developed hypoglycemia. He will. There is like in our hospital we have three things during CPR. If the patient developed hypoglycemia, and if the patient developed seizure. Okay, only three things I have to receive verbal order. I will not waiting for the order to be written. But out of these three things, I can't do anything without order. I have to ask the physicians kindly write the order, whether you have the system or you have the paper. Kindly write it down to me, then I will carry out it. But during hypoglycemia, seizure, and CPR, no. We have to do without a written order. Later on, they will write it for you. Process. During the telephone order and verbal order, we have to follow two strategies. If you receive a call or the telephone order, I have to implement the strategy of read back. He called you. Kindly, this patient's name, Muhammad Omar, file number 12379. You have to repeat it back. Do you mean 123779, Muhammad Omar? He said yes. Then write it down. Once he said, okay, the hemoglobin is 5. Do you mean hemoglobin is 5? Yes, hemoglobin. This is, we call it read back. Just to double check with him, the message or the data has been transferred successfully, and the same as he wants to say it. Okay, we have to repeat back. Even the physician call you over the phone, doctor, do you mean D50 or D5? No, I mean D50. Okay, D50. This is, we call it read back. When we are using writing and we have to read it back. Will acknowledge that order is correct. So I have to repeat back. So documentation includes date, time, and names of individuals who gave, received, and recorded. So I have to write the name of the physician. I have to write my name, who was received, my witness, everything, date and time. There may be circumstances when it's not visible to do read back. As we mentioned, during CPR, no repeat back, no read back, only repeat back. Give adrenaline. Doctor, do you mean adrenaline? Give fentanyl. Do you mean fentanyl? No, I mean fentanyl. Okay, you have to repeat it. And the dose as well. Give 2 milligrams Dormicum. 10, no, I mean 2. Okay. Then you can give. This is repeat back. Just to double check the order was received correctly. Okay. And also documentation is so important when applying the telephone order or verbal order with full details. If you are a nurse, you have to mention it in your nurse's notes. Also, the physician later on, he has to write it in the progress notes and in the instructions or in the doctor order. Here is some critical lab values you may report or receive a report regarding them. As we mentioned before, this is the lab. And you have to rely on the one at your hospital. Here, for example, potassium, the lab values, this is normal, 3.5 to 5.5. If less than 2.8, you have to report it. If more than 6.2, depends on the critical values that implemented on your hospital. Some of the hospitals, they say below 3, you have to report, okay? Depends, but I'm giving you here an idea. And you make sure these values, critical lab values, is disseminated and will be known from all the people at your hospital. This is the last point. We'll talk about it here in the effective communication, which is handover communication. One of the techniques that may provide a framework for communication between members of the healthcare team about the patient's condition is SPAR technique. What do you mean by SPAR technique? SPAR stands for situation, background, assessment, and recommendation. So if I am a nurse or a physician in the morning shift, I want to endorse the patients or the unit, okay? The unit to Hamda will be finished at we're getting a break like 12:30, okay? 12:30 for a break for 30 minutes. We'll be back at 1 p.m. Okay? SPAR stands for situation, background, assessment, and recommendation. We'll finish this now. Then later on, we'll be open a discussion, okay? At 12 till 12:30. When calling the physician, follow the SPAR process. Or even like between nurses, we have to follow the SPAR process. Even I want to, even the anesthesia wants to see the patients, we have to go with the SPAR process. Try to implement the SPAR process when you are doing with the other colleagues. If you want to endorse the case to your colleagues. So, first of all, we have to start with the situation. What's the situation you are calling about? Identify self, unit, patient, room number. Briefly state the problem. What is that? When it's happened? When? So, I have like patients developed hemoptysis or developed melena. I have to call the gastrology physician. I have a patient here and he's developed melena, and you have to introduce yourself. This is my name and I am ICU physicians. We have a patient here, GCS 10/15. He is on mechanical ventilator and he developed hemoptysis or melena. Just, try to describe the situation. Later on, talk about the background for the patients. Try to talk about the background. The patient is getting this kind of medication. Patient, he has a history of peptic ulcer. Patients, he has colon cancer history. All of these things. Also, you have to talk about the lab results and what's the fluids he's getting, if he has allergies or not. All of these things should be. Also here we have to talk about code status, like if I have a DNR patients, we have to inform as well. Even for the assessment, Then give their assessment. I did like this. There is abdomen is soft and lax. You have to say all your assessment. Even for the nurses when they are endorsing, they have to give the assessment for the patients. A neurological assessment or any kind of assessment should be mentioned. Also, your recommendation. Like what's the recommendation or what does she want? Example, not like if I consulted the gastrologist before, he recommended to start omeprazole infusions. This is one of the SBAR, and it comes under the recommendation. This is the end of second goal of effective communication. Here we go. We'll try to finish it within 30 minutes. The third goal, it's ensure safe surgery, perioperative, ensure safe surgery, perioperative verification, site marking time, out and sign out for surgical invasive procedures. This is the third goal of IPSG and should be implemented at your hospital. What we mean by perioperative care? There is a difference between preoperative and perioperative care. Perioperative care is a term used to describe the time around surgery, which is mean before, during, and after. All these kinds of time around the surgery, we call it perioperative. It generally refers to the period between going to the hospital or clinic and returning home afterward. But it can also include months of preparation and recovery. If the patient is get ready to do the surgery, okay, from this time till the discharge or finish the surgery or he got healed, we call it perioperative. But the perioperative period has 3 distinct phases. The first of all, or the first thing is called preoperative. This is before surgery, 1 day maybe, or at the decision of do the surgery. This is before surgery. This is has some preparation, preoperative. Also, the one intraoperative during surgery. Okay, once we endorse the patients to OR and he got on the table, we call it intraoperative, and there is many steps and things to be done there. Postoperative, when the patients finish the OR, when he get to the recovery room till he get to the unit. This is, we call it postoperative. So preoperative, before surgery, begins when the decision is made for surgery until the client is transferred to the operating room. During these whole things, we call it a preoperative. But intraoperative phase during surgery phase begins when the client is transferred to the OR. Once the patient gets to the OR, the intraoperative phase has been started till the ends with the client is transferred to the post-anesthesia care unit or recovery room. This is, yeah. But the post-operative phase after surgery onwards phase begins. This phase continues until the client is discharged from the care of the surgeon. Surgical team, what do you mean by surgical team? Surgical team consists of surgeons, the one who's gonna operate, anesthetists, the one who's gonna give the anesthesia to the patient, nurses, whether they are recovery room, holding bay, when they are getting to the OR, before getting on the table, we calling this holding bay, OR ward, OR or the ward nurse, and anesthesia technician who are involved in the surgery there, or circulating nurse. All of them, all of those, we call them surgical team. What do we mean by surgical safety checklist? It's a tool to improve safety operations and to prevent wrong site, wrong procedure, and wrong patient surgery. Usually we do the checklist, and there is one pictures later on, I will show it to you. This is surgical safety checklist. We have to do it before the patient's going to the ward as kind of preparation. And prevent, as we mentioned, wrong site, procedure, wrong patients, okay? We have to make sure this is the right patient. He is gonna do the right procedures on the right side. What do we mean by sign-in phase? The period before the surgical team prepares the patients for procedure. Timeout phase or surgical pause. This is, we have to do it before skin incision. We have a list. We have to make sure everything is clear. We have to do, okay, timeout, guys, surgical pause. Then we have to do this phase before do the skin incision, before operate. It's so important before starting the operation. In order to confirm that safety checks are undertaken and to take a final patient identification and procedure proof, we have to check skin marking, everything is ready. So we have to operate. Sign out phase, the period before the patient procedural team leave the procedural areas and it's done before moving. We have here sign out like counting. We have to count how many the instruments. We have to make sure about the suturing, everything. We have before the closure of the wound and everything, we have to do the sign out phase. If everything is clear, we have to discharge the patients to the recovery room. All of these things to be done intra phase. What's the purposes for this one? First of all, to promote patient safety by providing guidelines for verification of correct site, correct procedure, and correct patients for invasive surgical procedures. We have to do it to make sure about this thing. Secondly, to provide detailed implementation requirements, exemption, and adoption of special situation to prevent wrong procedure, wrong site, wrong patient surgery. Thirdly, to ensure that surgical team follows the critical safety steps. If we don't have these steps, every time we have like everybody will act with their own. We want to prevent these things. We have to keep everything systematic. If this procedure is applied for a patient, I want the B or X or the second patient will get the same process. This is systematic. Okay. Reduce number of clinical. Okay, the process to prevent wrong site, wrong procedure, wrong patient surgery implemented during all phase of interventions performed in operating rooms or other locations. Especially the process consists of three phases: verification, marking of surgical site, timeout. Verification should be done before with patient identification. Marking of surgical site should be done before OR and time out. Okay.
A pre-procedural verification of patient information is carried out, including patient identity, consent, full details of the procedure, lab test, and images. All patients having surgical procedure must have a site mark. The surgical site be marked to identify attended site, especially for the bilateral. If I have surgery on the right hand, I have to mark the right hand. And which part of the right hand? Forearm or on the shoulders, everything should be marked. Four-day surgical patients, marking is done. This is we done it in the unit. But four-day surgical patients, marking done is in the holding bay. Once we get to the OR, or just sometimes they will do it at the D-surgery department. Once the patient admitted there, we have to do skin marking there. We have to shift it to the OR. But we can't push the patient inside the OR on the table, then doing skin marking there. It's not allowed. We have to make sure everything is complete before going to the OR. The following cases where there is potential for errors, site marking is essential. For example, bilaterally organs. For example, right and left. Multiple structure, like index fingers. We have to mark them. If the operation will be done on the thumb, I have to mark the right thumb or on the left thumb. And the toes, okay, which one? The big toe, the little one, also lesions. Multiple level. For example, if I have like spinal or spinal cord, I have to mark the specific part. If I want it in cervical, I have to mark the cervical. If I want it in the lumbar, I have to mark the lumbar region. If I want it in the thoracic region, I have to, and so on. Exception for site marking. There is something we can't do skin marking for them, and there is exceptional for them, especially for single organ cases. Appendectomy. We don't have two appendicitis. So in case there is appendectomy, okay, no need for skin marking. If I have a teeth issue and the teeth to be extracted, no need for teeth marking, okay, because can't be, it's difficult. Also trauma cases with obvious wounds needing attention. If I have RTA and trauma and they have open fracture bone, no need to do the skin marking. Already it's obvious in front of you. Already the bone is out and the leg is fragmented. Okay, with obvious wounds. The site is marked by the surgeon who will perform the procedure. Should be done by the surgeon itself, not by someone else, not by the nurse, not by someone from the team. Should be by the surgeon itself, the one who's gonna operate. Okay, we have to make sure and emphasize on this point because it's related to the patient safety. In patient's record, the name of the physician who marked the sites, we have to document all these things. Who did mark the skin in pre-op checklist and also in the progress notes. Nurse must not mark the surgical and procedural site. The patient is involved in the marking process. Marking must take place with the patient involved, awake and aware if possible, and patient. So we have to introduce ourselves. We're gonna operate you, and this limb has an affected, and we're gonna mark it. to make sure the patient will be cooperative with you. He will not erase it or taking a shower and it will be erased. In case it will be erased, he has to report it if he is awake. If patient refuses to be marked for a procedure, the refusal must be documented. So we have a refusal form. We have to ask the patient to sign it or the relative to sign it. Also the physician and the witness. This patient, we have to give all the details. The procedure has been explained to the patients why the patient is refusing the procedure. And the procedure is this and that. And the complication it might happen is this and that. So the marking method is consistent throughout the hospital. The hospital surgical mark is SS, surgical site. We have to write not X, not something, anything like just dots on the skin. No, we have to write SS. It means surgical site. The mark must be ambiguous, clearly visible, marking the site to the safety patient by finding wrong site surgery. The mark is visible after the patient is prepped and dripped. Use a permanent marker. We have to use the permanent marker to prevent it will be deleted. Mark must be made with indelible skill marker to remain visibility. Waterproof pens, it means the permanent mark. Verification of the site mark must take place during site mark must take place during the sign-in and timeout. Final check, which is mean timeout, is conducted before skin incision. We have to do it. We have mentioned this one before. Timeout is initiated by circulating nurse before the incision. Okay. During the timeout, the team members agree on the correct patient. Okay. We have everything should be agreed. If there is some conflicts there, they have to solve it before operate the patient. Especially when two teams will operate the patients, especially with orthopedic and GS or neurosurgery, and they will join them or maxillofacial or yes. Who's gonna first? What's your part? What's my part? They have to. Also, we have to get consent for the patients before operation. It includes patient's full name, name of the procedure, and site of procedure. Then we have to get a signature of the patients and the physician or the surgeon who's gonna do. We have to get the consent, surgical consent, anesthesia consent for all the patients who will go for surgery. Also, the pre-op checklist or pre-operative checklist should be completed accurately, filled up and signed, and should be signed as well by the OR technician when they receive the patient. It means all the pre-op checklist has been implemented and checked, and everything is available there in the checklist. So if the checklist wasn't complete, we have to complete it or the OR will be cancelled because one of the items there. Like if the patient's for surgery and they mentioned he needs 2 units of blood. We have to make sure when I prepare the patient, the 2 units of blood is prepared already. Otherwise, they will not operate the patients. Surgical safety checklist must be checked prior to the commencement of the procedure, which includes sign-in, phase, time-out, sign-out, okay? The sign-in phase must completed before the induction of anesthesia to confirm the following: patient identity, site, procedure, consent, site marked, pulse oximeter on the patient, and functioning. To keep the monitoring of the vital signs. The final safety checks or timeout must be undertaken and occurs immediately just before the skin incision. Prior to the start of any surgical, timeout should be completed. Okay, timeout. I have to double check patient name, correct patient, correct surgical procedure, and correct surgical. Guys, it's electronic registration. Maybe the link will be sent down and you can register your name if you didn't register. Nobody is like taking the attendance from the chat, just for your information. Invasive procedures performed outside of the hospital operating. Any procedure invasive, not in the OR, also you have to do the timeout. For example, if patients for endoscopy or cystoscopy, bronchoscopy, anything of these things, we have to do the timeout. Not necessarily every timeout should be in OR, no. Timeout should be even in the on the floor, especially in the critical areas. They are doing these procedures in ER or in ICU. Removal of lesions, biopsy, intervention radiology. Also in intervention radiologist, if they want to insert Bermicath or thrombectomy, they are doing any kind of under interventional radiology, they have to do the timeout. Percutaneous aspiration of fluid. As we said, the aspiration, removing some fluids from that. We have to do the timeout. Any procedures involving conscious sedation. Also, any procedures will do conscious sedation for the patients. It means giving light sedation. It may not affect on the level of consciousness, and we need also do a timeout, especially in emergency, ICU, endoscopy, and bronchoscopy and radiology. Sign out shall be completed before moving the patients from operating room. We mentioned this. Managing discrepancies, we mentioned this as well. If they have to solve it before operate the patients. Preoperative verification, the unit nurse and OR nurse coordinator will perform verification over the phone if he is ready or not ready. Then once they endorse the patients to OR, they have to do verification, verify the patient's identity, verify mark site. I have to make sure mark site is there as OR nurse. Ensure that the consent is available. Ensure the availability of radiographic films if needed. Nowadays it's on the system. Document all the relevant information listed, like the checklist. All is there. Both unit nurse and OR nurse coordinated, affixed by the end. Okay, once they checked everything is complete, the unit nurse, she has to put her names there with her signature or stamp. Also the OR nurse, he sign on the receipt, everything is complete. Sign in phase, the circulating will be done with circulating nurse to make sure about the name, correct procedure, and everything. Site of procedure. We have to confirm if pulse oximetry is on the patient and functioning. Why? Because we want to know the heart rate and the patient will not be collapsed during the procedure. Or maybe the patient developed tachycardia. Maybe we know that the sedation wasn't proper. We have to adjust them. Will be finished within 15 minutes for open discussion for 30 minutes. Break from 12:30 to 1 p.m. We'll be back at 1 p.m. Also, we have to check if difficult airway aspiration risk. Also, we have to make sure the patients, some of the surgeons, they ask you to give thrombolism prophylaxis, the famous like Clexane or heparin prior the surgery. Some of them, they are not asking because the patient's high risk. We can apply the pneumatic compressors during the OR to prevent the DVT or thrombosis. Prior to skin incision, timeout, we mentioned we have to make sure everything is clear. So we have to time out, pause, check everything before skin incision. All members have introduced themselves by name and role. This is me, Muhammad. I am the OR nurse, so I am the surgeon. Everybody has introduced himself to know everybody. Correct patient identity, correct procedure, correct site, availability of correct implants in case there is kidney transplant. We have to make sure about everything is ready. Also, confirm if antibiotic prophylaxis has been administered within the last 60 minutes. Here we go with the, we have done here with the knowledge part, but I will show you some preoperative checklist. This is from the Ministry of Health. Okay. It has many parts. The first part here on the right side, the patient's data. Okay. And also the diagnosis, everything. Also, we have the checklist itself. We have to go with each step here. Then we have to tick yes or no. Identify based on hand checked, surgical consent signed, anesthesia consent signed, blood transfusion signed. In case there is requisition, how many units they need, surgical site marking done. Everything should be consultation, everything here, lab results, CBC, BTT, urine analysis, anything that's with the patients, we have to make a tick there. Also, we have to write the vital signs preoperative. If in case the patients, there is an order to give enema before the OR, we have to write the time there, when did we give. Prosthesis removed, like dentures or lenses, contact lenses. Also clipping, nail polish, everything should be checked before the OR. Here we go. There is two consents here in front of you. The one on the left side, this is the general consent. This is from, okay, approved by MOH, okay. General consent, and every hospital has their own consent, but this is here just to show you. Every patient admitted in the hospital, they must have the admission consent or general consent. It means they are agreed to be admitted. This is their rights to accept the admission. If no consent of general consent, admission consent, no admission. The one on the right side, this is the surgical consent, should be filled by all. The signature of patients or his relative, the surgeon, also the name of procedures, the site, everything. While here, the one on the right side, this is the anesthesia consent, or in case there is conscious sedation. We have to ask the anesthesia to fill it, also the patient to sign it. They will be notified. They will be notified as well, okay, by anesthesia. If this is general anesthesia or local spinal, this kind should be discussed to the patient. Also, we have the blood consent. should be signed by the patients. We can't give blood without consent. Here the handover surgery checklist. Okay, here the handover. So we have to check everything. This is nurse, anesthesia staff, and also nurse, recovery room nurse checklist, and the ward. Before receiving, when the patient getting from the table, from the ward to the recovery room, the second column, while the third column when the nurse came from the floor to take the patient back. This is the end for this lecture. Thank you so much for listening. I think we did it on the time, almost now 12. So we have an open discussion now. آمين وإياكم أخوي عبد الله يعافيك أختي غادة. Thank you so much for listening for the first part. We have done now with the 3, and after the break we'll start with the, and this is I think one of the, this is the heavy parts, while the parts after 1 p.m. it will be gonna easy, and yeah, just to give you some motivation. I'm sure it's gonna be easy. Now we finished patient identification, also effective communication, and surgical sites, and right procedure and the right site, also, or prevent wrong patient, wrong site, wrong procedure. So any question, guys? Yes, we'll be back at 1 p.m. Supposed to be from now 12 p.m. to 12:30. We have an open discussion. If anything lacking, do you guys do the same strategies at your hospitals? Do you do yes, Ali? Yes. Allah يعافيك أختي تركيا نورا. Yes, that's good. Really, it's important, guys, especially when we know if we didn't implement these things. To be honest, I did some visits, do some auditing for outside hospital. Really, it's gonna be harm for the patients if we don't have good system and good strategies. Really, there is a chance to the patient will get harm. So we have to work on them, whether we are supervisors or we are staff. All of us, we have to go towards these things. الله يعافيكم الله يعافيك مها عازف. No, where is Abdul Wahab? If you have any questions, kindly could you write which regions or which city you are in, guys, just to get some an idea about you, especially when nobody especially nobody is answering. That's nice. We got some colleagues from Riyadh, Jeddah. Oh, nice. Medina, Ali, mashallah. Related to the hospital. Maha, the IPSG, this is one of the standards the Sibahi is looking for. So we have 6 IPSG. Everybody is do it on their own, but they have to do it on the right way. For example, we do it like this in our hospital and some hospital in Medina region. But if you do like, for example, the high alert, you have implemented in certain way, but you have to implement it, the 6 goals. Usually during the Sipahi visit, they're asking about these 6 things. They will check the patient identification. Do this hospital do it right? Then they will give you pass. Otherwise, they will fail you, whether Sipahi or GCI or any other accreditation company. They will check the if do those guys do the right things for the surgery. How do they know right patient, right site, right procedure? Also, they will see if you are doing double checking. Yeah. Yeah, it's so important, the IPSG. You have to implement it and make sure everything in the hospital will be done. That's nice. Nice to meet you guys from different cities in Saudi Arabia. Jeddah, Taif, Jeddah, Riyadh, MashaAllah, Asir. That's nice. Okay, now it's 12. You wanna have a break now? You guys give me that sense, just send us to break. We'll not ask you. It's okay if you don't have any question about the previous slides. Yes, we need. This is, yeah, Nasreen, I think badly needed. Anyway, we can get a break 12 to 1 p.m. We have to get back here 1 p.m. to continue our lectures. You can have good break and refresh your mind. We need to get more participation in the second part. Thank you so much. We'll get back here at 1 p.m. We get back again. Okay, maybe 4:30. We are not sure. Supposed to be to 5 p.m., but we're trying to finish it. Once we finish it, but almost maybe we need only just 3 hours maximum. Wish you the best, guys. Shall we start? Okay, here we go. We discussed in the first part of the lectures today the patient identification, the first goal of IPSG. Also, we talked about effective communication. We also about the promote correct site, correct patient, correct procedure. Now we will be talking about the fourth goal of international patient safety goal, which is high alert medication and required safety measures like look-alike, sound-alike medications, and concentrated electrolytes and narcotics. I wish it will be amazing and interactive with you. Anyway, by the end of this lectures, we're gonna have like maybe 5 minutes, quick discussion. If anyone needs to ask, just write your questions down and we will be open it up by the end of this lecture. Okay. So here we go. First of all, we need to define what do we mean by high alert medications. High alert medications are drugs that involved a higher percentage of medication incidents or that bear a heightened risk causing significant harm when they are used in error. So this is high-risk medications. What they want to say, once you give it, it will give the effect straight away. So if you give some of the high alert medications in wrong way, whether the route, whether the dose, whether the amount of given per minute, it will affect on the patients directly. Okay, this is what we mean by high alert medications. So what's the purposes of we are focusing on high alert medication? First of all, to establish guidelines to identify and standardize the handling and use of high alert medications. So we have to keep a list, usually in each hospital, to know this medication is high alert medications or not. We have to questioning ourselves. In case this is not high alert medications, we have to follow some rules. We have to treat it as a normal medications. While if the medication is high alert medications, we have to follow certain rules that implement and ensure that our practices will be safe for the patient. Okay. Secondly, to provide the highest quality care by improving medication safety practices of high alert medications, including storage, prescribing, dispensing, and administering. Once we know these are high alert medications, so I have to store it with a standard or with specific rules. Describe it with specific rules, also dispensing and administering. Third things are to outline steps to prevent errors that may result from confusion of these medications. So usually we say or recommend every hospital has a system for the safety of high alert medication. We could say the hospital implements the multidisciplinary plan for managing high alert medications and hazardous pharmaceutical chemicals. It includes identification, location, labeling, storage, dispensing, and administration of high alert medications. What do you mean by multidisciplinary? Multidisciplinary when many teams engaged in one practices. For example, we said the high alert medication is multidisciplinary plan. So the pharmacist will engage, nurses will engage, physician will engage. So this is multidisciplinary. It's not a concern of one party and ignoring the other one. No. It's sharing responsibilities. So the hospital identifies an annually updated list of high alert medications and hazards, pharmaceutical chemicals based on its own data and national and international recognized. So it's not about I need this one as a high alert medication or not. No, it's standardized and it's international standards. So they classify these medications as a high alert. We have to consider and treat it as high alert medications. So recognize organizations. The list contains but is not limited to the following. So we have some, I enumerated some down. It shows here from 8 to 8, but it's not limited to this list. You may find another, we can say it's high alert medication. So just be careful and follow the standards at your hospitals. First of all, we could say controlled and narcotics medications. This is the medication where we see them in the cabinet there, in the units, or in the pharmacy with the double lock. Okay, this is the first one. Neuromuscular blockers as well, like esmirone, cocorium, and what else? Dormicum. This kind of neuromuscular blockers, it's kind of high alert. Chemotherapeutic agents. Any chemotherapeutic agents considered as high alert medication. Atracorium, yeah? Yes, Ali. Nice. Okay. Concentrated electrolytes like hypertonic sodium chloride, concentrated potassium salt, anti-thrombotic medications such as heparin, warfarin, also insulins is a high alert medications, anesthetic medications like propofol, ketamine, or other medications as identified by the hospital. As I mentioned before, it's not related or not limited to this list, while some other hospital they are considering, but we have to work on them on a certain way. So the hospital plan for managing high alert medications and hazardous pharmaceutical chemicals is implemented. This include, but not limited to the following. Okay, so we have a plan. How do we control on them? First of all, improving access to information about high alert medications. Improving access, like knowledge, skills. So some of the pharmacy provide some barcodes. Once we scan them, it will get us to the manual, pharmacy manual. So I have to know everything about this medication to minimize the errors. Okay, this is first of all. Even for anyone coming to the hospital, we have to orient them regarding what do we mean, especially for the newly graduated and hired in the hospital. Or some of them, they are coming from other hospitals. They are not implementing the high alert medications in the on the proper way. Secondly, limiting access to high alert medications. As I mentioned earlier, every narcotics or anything or controlled drugs supposed to be in a cabinet, metal cabinet. Can't be break down or broken. You can't just access it easily, and with double lock. And we'll talk about it later, but anyway, with two different persons. For example, maybe one with the charge nurse and the second one with the most senior or qualified nurse. Or one of the head nurse with the head nurse and the second key with his or her deputy. Can't be two double keys with the same person. We did double keys to controlling them by two persons. Third one, use auxiliary labels or computerized alerts available. So we need to keep a label on them to show this is high alert. Usually it comes with red, what we notice, or in the hospitals. It comes in reds, it's right there, high alert medications, whether heparin, insulin, fentanyl, anything, such of these, propofol. Most of them, they have label on them because it shows that be cautious, slow down, okay? think twice. Bring your partner or bring the second verifier. It's independent checking. Okay. The fourth thing, standardizing the ordering, transcribing, preparation, dispensing, administration, and monitoring of high alert medications. So should be all of these processes should be done by two qualified people or two qualified healthcare practitioners, whether the physician and nurse, the nurse and pharmacist, and two nurses. Always we have to go with two. From A to Z. Employing independent double checks. This is what we identified before, independent double checking. We defined them before. Here we go. The hospital develops and implements standard concentration. So we have to focus on concentrations here for all medication administered by intravenous infusion. So most of the medications, the high alert medications, usually we prefer give them with the infusion pumps. Can't be, can be sometimes with the small amount, but usually for the long run or infusion, we have to use the infusion pumps, but we have to more cautious when we are giving. Okay. All concentrated electrolytes and high alert medication must properly labeled with red warning sticker, high alert medication, for further dilution. So, for example, if I have any one of the things I mentioned before, whether narcotic, controlled, concentrated electrolytes, chemotherapy agents, should be with proper order from the physician. Okay, should be in the medication sheet or on the system in the instruction, and should be included, okay, on the system as well. Okay, and we have order and should be written in the medication sheet by privileged physician, qualified physician. He is able to order these things. Okay. Preparing, yes, some of the hospital preparing my pharmacy. Do you mean like the Omnicell, the automated machine dispensing? We do like the Omnicell, yes, the Omnicell, but Omnicell only dispensing, okay, but our issues with the preparation. If you want to prepare, we do Omnicell, the ADC machine, okay, but the preparation, we need to double check about the order before dispensing them. First of all, the physician will order and include. Okay. Secondly, two qualified nurses, they will come and check the order together. This is good. Do you think? Yes, yes. Then after that one, they have to dispense it. Whether if you have the Omnicell machine as Ali mentioned, ADC machine, or we are call it Omnicell. It's like automated dispensing pharmacy machine. Usually it will be located in the units. Can be, or you can dispense it from the pharmacy, you and the pharmacist. Like here we are doing double checking, independent double checking. He will dispense, he will check, he will dispense, he will give it to you, then you're gonna check by yourself. Don't rely on his checking. Later on, you have to bring it to the units, or if you take it from the Omnicell or ADC, you have to prepare it in the medication room. After checking the orders, dose, route, everything about the medication expiry, you have to check it well. Then you have to do the patient identification before administering. You have to go and check. Then your colleague will go and do checking patient identification as well. You see, guys, all the things in trust, that it's connected to each other. We finish the patient identification, but still we do it when we do effective communication, surgical wrong patient, right patient, right site, right procedure, also in high alert, everything. The things, that's why we said it's IPSG, International Patient Safety Goals, which means really the six things, it will work together. Okay, it will work together. So you have both of you guys double checking the patients, comparing the ID band with the file if you have it, or just double check it with the system. Then administrate depends on the order says. If it's like infusion, use the infusion pumps. If it's like just like fluids like KCL or the other things, we prefer to use the syringe, not the syringe, infusion pumps, and do syringe pumps for the other, the 24, the continuous medication. So the pharmacy, they say here, labeling process must be done by the pharmacy staff. Yes, you are not authorized in the floor or in the units in general wards or even in ICUs or ER to label the medications. You have to get them labeled from the pharmacist. Okay, later on, the pharmacy department provides the following general guidelines for the proper handling of high alert medication, included a defined list. Okay, this list you'll get it from the pharmacy. Okay, kind of these things you will get it from the pharmacy. You see, this is the list of high alert medications. It's classified to the main, like adrenergic agonists and adrenergic antagonists, and yes, like as we see here, adrenaline, midazolam, dormicum, many. You have just to know also the concentrated electrolytes here mentioned down on the right. So we could say concentrated electrolytes, magnesium sulfate, potassium, sodium phosphate, potassium chloride, and sodium chloride are not allowed as floor stock in patients' care units, except as part of crash cart medications. Only in a critical area is accepted. Okay. As we know, some units or general wards or ICUs, critical care units or emergency, they have inpatient stock medication. So for example, they keep I opened the Ventolin, like nebulizer for the patients. I have specified drawers for this patient. We can keep the multi-dose uses, and supposed to be discard, and we have to label it once we open it, and supposed to be discard depends on the manufacturing instruction. Having said that, in the critical areas, which is emergency department and ICUs, it's okay to keep a space for the concentrated electrolytes. Like they have their own stock, like the KCL and these things. But now with the ADC or the Omnicell, the automated machines, we don't need them. We don't need them because instead of keeping them in the drawers with, even you are keeping a key, the Omnicell would do the same with double checking. If you dispense there, if it's high alert, the machine is smart and it will ask you the second nurse verifier. Okay.
So this is again independent double checking by two pharmacists in the dispensing from the pharmacy, and independent double checking in the dispensing from floor stock by two competent nurses is mandatory. This is for those who doesn't have the Omnicell. It's okay to keep drawers, but should be locked, okay? And should be locked. And should be away from the narcotic and controlled. Shouldn't be both together. Okay, you can specify a place for the concentrated electrolytes or heparin or this stuff. Also, the insulin, if you are keeping or it should be kept in the refrigerator, should be the refrigerator is locked. Okay, can't be accessible for all, should be locked, and the keys with the charge nurses. And if any nurse wants to open or just to prepare insulin, she has to do it with the charge as second verifier, or she has to bring another colleagues to do the same from A to Z. Checking order, preparing together, dispensing, preparing together, and administering together. And they have to sign also, to sign together, okay? Double sign. Once they finished, they have to sign as well. The first nurse will sign, then they have to make slash, okay? And the second one, she has to sign beside her names. Or if they are using the system, the first one she has to carry out on the system, and the second one she has to come and do as witness there on the system. She has to enter her account data. For sure, yeah, everything is with the label, Ali. Yes, excellent. You have to prepare everything, keeping label, and even before preparing, you have to make sure it has the high alert medication. And usually, it's the responsibility of the head nurse and the charge nurses, not keeping something in the cabinet for narcotic or in the drawers without high alert medication when they receive it from. But if they have the Omnicell, it's the responsibility of the pharmacist to fill up the Omnicell with this medication, and he doesn't have to leave them without labeling and keep the high alert stickers. Double checking by administering nurse and second nurse verifier also mandatory, as we mentioned. High alert medication cabinet key must be in the position of the head or charge nurse or his or her designee to ensure its availability. So every unit has to keep a cabinet there for the narcotic or high alert medications, narcotic or controlled drugs. Shouldn't be with one key, or shouldn't be the both keys with the head or charge. We have to separate the keys. Also, we have to keep labels there inside. What about the name of medications that's inside the cabinet with expiry date and the amount of them? For example, I have fentanyl like 500. I have to know supposed to be 200 ampoules inside, or 100 ampoules inside. I have to check them one by one, expiry, and I have, even I receive from the night shift, I have to check them one by one. I have to make sure if like 10 or 20 used, I have to double check the prescriptions, because you're gonna go down and replace them or pass by the pharmacist and replace them, handle them the empty files with the prescriptions. They're gonna replace it with a new one. So do it one by one. You have to check all the things inside: expiry date, amount, how many dispensed, how many remaining. Then you have to sign with the one endorsed to you. If you are in the morning shift, you have to count with the night shift charge. You have both of you count. She has to endorse to you, and she has to sign, close her shift, and you have to open up
like you received this amount from her, and you have to sign on that one. Once you endorse to the second shift, you have to do the same. You have to endorse to them the amount remaining, and they have to receive the same. Also, we have to keep a registry beside the narcotic cabinet. If anyone open a sedation or narcotic from the cabinet itself, they have to write it down. They have to write who did order it, the name of the patient's file number, and with second verifier, how many ampules did they take. The head nurse will sign, or charge nurse with her, with second verifier, okay? And someone will go with her to give as second verifier. General guidelines to reduce risk of using high alert medication. First of all, we could say storage of high alert medication and concentrated electrolytes. As we mentioned before, if we don't have this machine, the Omnicell or the ADC machine, the automated machine, we have to place them in secured place with a key. Okay, can't be accessible and reachable for all. It may be used or misused, okay? Locked cabinet away from regular medication stock. As we mentioned before, if I have floor stock medication, this is for the concentrated medication, or if I have inpatient medication, okay, I have to keep them away. And also with high alert medication label. Also, we have an approved list of high alert medication must be available in the storage cabinet with the name, medication, strength, quantity, expiration date. For example, I have to do a list there. I have to write there, I have heparin for 10 ampules. And the strength would be to 25,000 international units. And they have quantity like 10, as I mentioned. And the expiration day, I would say December 2024. So every month I have to go and randomly check. And daily I have to check their quantity and expiration date. Usually we set these only in critical care area, in emergency and ICUs, because they use them a lot. But we are not expecting to keep some concentrated electrolytes there in the general wards, because rarely they use them. In case they use it a lot, possibly the patients for ICU admission, they will do consultation, then their patients may be transferred to the ICUs. So no benefit to keep these medications in there, especially when we know their routine work is not like the ICUs. Here we go. This is the signage, the red one. Do you see them? Usually we have, but this is for lookalike. Okay, but the one for high alert medications look like this one. But now we have to talk about the lookalike, sound-alike. Lookalike and sound-alike, we have to label. It's one of the strategies, like to prevent the errors, especially in the narcotic controlled, also the concentrated electrolytes. High alert medication must be properly arranged on shelves. What do you mean, like high alert medications must be properly arranged on the shelves? I have to separate them. Like if I have dopamine and dopamine, I have to differentiate between them. Maybe I got the name like fast and I wasn't rushed. Then I got the wrong medications. And instead of taking dopamine, I took dopamine. How do we differentiate? We have to use tall man letters. Tall man letters. You see here, methyl, okay? They wrote the prednisolone, okay, in large, okay, in capital letter. Only the one, not the similarity. We have to keep the similarity. Like in dopamine and dopamine, both of them ended with mine. We have to keep that small, but we have make the dopamine DOB. This is with large letters. While dopamine, we have to keep DUB with the large letters. Then we have to keep a LASA. Okay, LASA signage, label. I have to keep it beside them. This is LASA. What do we mean LASA? It's abbreviated for look-alike, sound-alike. Even for D5 water, even if you are using D5 water or D5, not D5 water, if you have using D5 normal saline or D5 half normal saline or D5 1/4 normal saline, you have to keep beside of each of them the label of LASA. It means once I get it, there is LASA. It means there is another medication look alike and sound alike of this medication. Be careful. So we have to implement the two things for the look-alike and sound-alike medication. We have to keep LASA label beside them. Also, we have to write them or labeling them or type them with tall man letters. Here we go, guys. We could say, how do we do the tall man letters? Is it clear for you? Any doubt about them? Yes, yes, Ali. Capital in sum, yes. As you see here. Is it clear, guys, to you? Do you know how to do the labeling? We need to hear from the rest as well. Harzam, yeah, clear. That's Afnal. Okay, nice. Nice, yeah. Don't sleep, guys, okay? Almost we are there. Okay, so here, dobutamine and dopamine, okay? We enlarged the letters. We kept them enlarged, tall man letters. Here, tall, just to differentiate. Even you see here fentanyl. So fentanyl. So sounds alike. We have to. Even for the one look alike, like heparin, insulin, if they are just near to each other, we have to separate them. Also for be careful for the fluids. If you have like 5 shelves, keep one D5 normal saline in one shelf, half normal saline in the other shelves, in separated places. Because some of them, they want to D5 normal saline, they got the 1/4 normal saline or the, and vice versa. Narcotic and controlled medication must be strictly controlled all over the hospital to prevent misuse or dangerous mixed up, and to be kept in steel cabinets with double locks. As we mentioned before, you have a steel cabinets, double locks, every lock with double locks and double keys. Every key has to be with someone else, not both of the keys with one person. Also, as we mentioned, registry book for high alert medications and narcotic and controlled drugs must be available in each unit where stocks are maintained and locked. If you have some stock at your units, you have to keep a registry book. As I mentioned before, okay, I'm gonna open a narcotic now with the head nurse and the charge nurse. We'll be 3 together. Okay, we have to check the order first. we have to make sure it's written there in the medication sheet, because we're gonna sign at the end. Same name of the medication, same route, strength, frequency, everything. And usually we have to get a new order for the medication, high alert medication, supposed to be, it will be requested daily, because these kind of medications should be reviewed by physician daily. Okay, we are giving sedation daily, but we have to review them. The patients may need, may not. We can't open it like this, giving the medication for the one order. I can use it for the whole week now. The narcotic and controlled supposed to be with daily, and with each prescription or with each prescribing, I need new prescriptions. It means really the patient's need and the physician's decision. And this is the willing of all, okay? We have to be more strict on this kind of medications. And after, also we have to write the name of the patient's MRN, or keep the patient stickers if you have it. The name of medications you're gonna take, strength, how many ampoules, what's the order of physician, who did the order it. Then the head nurse has to sign and put his stamp or her stamp. The other one, the deputy or the charge, and also the first nurse who's gonna give. She has to put her stamps, then the preparation. Both of them, they will go and prepare together, because most of these medications should be diluted well. So they have to dilute them with the right dilutants, whether normal saline, D5 water, whatever. They have to do it together. Later on, the second nurse will sign with her after administering, and do double checking and patient identifications there. Okay. Also, proper endorsement must be done between the head nurse and charge nurse or their designee at the beginning of each shift. I think we explained this point before. If the night shift endorsing to the morning, everybody has to close their census for the narcotic, and every one of them has to sign upon receiving and endorsing. Prescribing of high alert medications. This is high alert. Okay. All physicians must write daily orders. As I mentioned before, shouldn't be one order can be carried out for the whole week. Now, every order for narcotics is supposed to be daily requested. For concentrated electrolytes, okay? Heparin, insulin, and all narcotic and controlled infusions for all admitted patients. Also, we don't have, there is a standard abbreviations. We may use them. And if you don't have a standard abbreviations at your hospital, you have to create one. For example, some of the physicians, when they are ordering anything with the unit, like insulin, 10 units, okay? What they write? 10U. Some of them, instead of writing U clearly, they will write it as O. Then we got confused. Is it 10 units or 100? Okay? So be careful. Don't use abbreviations in the high alert medications, so that instead of writing mcg, okay, we have to write micrograms. Okay, and instead of writing IU, international units, we have to write international units as it is, to not make other confused. And they may give high dose to the patients. such as use, the words units must be spelled out. Use of U is an abbreviation for units in medication orders, heparin, insulin, may be confused with 0. You see? And instead of writing U, maybe the physician meant it as U, but we got it as O, especially with handwriting, and may result in a 10-fold overdose. All intravenous drips should have standardized drug concentrations in molecule, okay? Verbal orders and telephone orders are not allowed when prescribing concentrated electrolytes. We said you have to review the policy and procedure at your hospitals. Because the telephone order and verbal order only specified for certain situation, for some medications, we can work and deal with them. You can't apply the telephone order and verbal order on all medications. Because the high alert or concentrated electrolytes, it's very dangerous. Can't be done over the telephone orders or verbal orders. Supposed to be with attendance of physician. He has to write it down. Okay, now we have to follow the civil rights of medication administration, which is we have to make sure right patients. How do we know this is the right patients? How do we know? How do we do? By patient identification. This is the right patient. Right medication, how do we know? We have to check the physician order and we have to compare it with the MR sheet or medication sheet. If you have it on the paper, do it on the paper. If you don't have it on the paper, check the system. Check the progress notes or instruction and compare it with the medication. How do we know the right dose? As well, we have to check the orders and compare it with the MR sheet. How do we know the right route? The same way. Right time and frequency. We have to check it there. Right documentations. What do we mean by right documentation? Right documentation, if the physician wrote an order, this is right documentation. If he wrote it in the medication sheet, this is right documentation. If the nurse and the charge and the head, they took it from the cabinet and they documented in their registry for narcotic, this is the right documentation. If the nurse went bedside and give it and sign it, okay, with a second verifier or with her colleague, this is proper documentations. Also, we have document for the electrolytes and concentrated electrolytes and controlled and all the sedations supposed to be documented there in the nurse's notes, and the physician as well, he has to write it there with full details. 7 patients response. After we give, we have to see the patients. Some medications will do side effect for the patient. Even you are doing it on the right way, but sometimes they make nausea for the patients. Sometimes they will affect on the blood pressure. Some of them, they will affect on the heart rate. So we have to monitor the patients after you giving these kind of medications. If there is side effects or undesired outcomes happened, you have to immediately inform the physician, do vital signs, and do the depends on the policies that I instructed you. High alert medication must be prepared and administered by administering nurse with second nurse who will perform independent double checking and verify the following. As we said, both of them, they will do the same. She or he check, I will check. She do patient identification, I will do the same. Independently. It's not together like at the same time, no. So here the point or the number 5 says documentation by affixing her signature in the MR sheet. Both of them, if it's high alert, supposed to be double sign. All these instructions for the free fire. And the nurse, she has to do the same of the 5th one, just to make sure and to inform you this is so important. Documentation of high alert medication. High alert medications and concentrated electrolytes must be independently double checked before dispensing by the head nurse charge. First nurse and second nurse verifier must be documented in the registry book. Administering nurse must sign in the MR to document the administration. Yes, we jumped, I think, maybe timing. Anyway, almost we are here. So the name verifier must be documented in the nurse's notes. This is the documentation. Okay, maybe the slide is timed. But anyway, so everything will be documented in the nurse's notes, in the medication sheet, and then everything. Okay, okay. Nice, nice. Okay. Guys, this is, I think, the end of high alert medication. Thank you so much for the listening for this part. Now we will be moved to the 5th one. Okay, now we will be moving to reduce the risk of healthcare associated infections. Most of us aware about the healthcare, most of us aware about the infection control guidelines. And we have to know it by heart. We have to know it by heart. Because as we mentioned in the introductions early morning about the percentage of the risk that may resulted from the healthcare associated infections. So what do we mean by healthcare associated infections? Any infection that's coming to the patients from the healthcare workers, visitors, anyone. So are those acquired by patients? It means the patient got them. The infection got it, okay, by the patients. From where he got them? Healthcare workers, visitors, even the visitors. During the visiting time, they may bring some infections from outside. If they got a COVID and they're visiting some patients in the hospital, and maybe if they have TB or another thing. Okay. The most common healthcare associated infections include, I think most of us guys are aware about respiratory infections, urinary infections, surgical site infections, bloodstream infections, and others like soft tissue infections, bed sores, skin infections, peritonitis. Have you heard, guys, about the Go Green, the campaign for the MOH, Ministry of Health in Saudi Arabia? Have you heard about Go Green these days? Yes, Hatun, yes. Okay, and the strategies of infection control in the Ministry of Health. Really, guys, these things is so important, whether for the patients, for the institution, for even for you, like, or for us, like healthcare practitioners. Imagine if you have a patient supposed to stay 7 days and he got infection. We mentioned early morning, he will get maybe the double days of staying. So don't underestimate these things. Be cautious. Even you are, we know some of us like have shortage there, but this is not allowed us to break the infection controls. You are not allowed to move from one patient to another with the same gloves, without doing hand hygiene, getting to the patient on contact precautions. We are going inside without PPE, isn't it? You are with or against? What do you think? We have to follow the infection control guidelines. For example, if I have patient with respiratory infections, okay, and it's contagious, what shall we do? Which type of a precaution I will put it for the patients on COVID? Okay, let me hear from you in the chats. If you have a patient on COVID, what's the signage you would put it on the door or on the room? And what type of isolation the patient should be in? Okay, do you hear me, guys? Are you here? Airborne isolation, nice, Hatun. Yes, airborne isolations. And we have maybe color. We use the blue color for the airborne isolation. Nice, Mashal. Okay, airborne isolation. Nice, Maha. Okay, Salim. Okay, airborne isolation. If you have an airborne or patients with an airborne precautions, whether COVID, TB, we have to put them in negative rooms. You have a negative rooms. What's our responsibility regarding the negative rooms? Yes, negative rooms should have a monitor outside the room. Should be and must be shows in the negative always. The door should be closed. Nice. What else? The rooms. Okay, we have to put the signage of airborne there at the door itself. This is airborne precaution. Also, supposed to be this room or the patient in negative rooms. With what do we mean by negative rooms? The air will be go out, filtrated and go out. It will not come in the unit, return to the unit. So because the pressure inside lowest than the unit itself. Usually it's -2 and more. Room has negative pressure. Nice. We have to do monitoring, guys, on the room. We have to check them every shift. The room, the negative room is working or not. Sometimes it has some issues there. You have to call the maintenance. And we have to do monitoring there. And even for the visitors, we have not allowed them to get in. There is anti-room. Okay, it's a room. Okay, it will stay between two doors. You have to open the doors, then you will find the sink and the PP. The second door, once you open it, you will get inside the negative rooms. If you don't have negative rooms, what shall you do, guys? What shall you do if you don't have negative rooms and your patients need airborne precaution? What's the alternative? Yes, Harzam, HEPA filter, nice. Yes, if we don't have the negative rooms, we have to keep HEPA filter there at the just near to the head of the patient. Okay, HEPA filter. And we have to work on the negative rooms If it's not available in your unit, just seek with your colleagues and the physicians too, especially for the TB. Maybe we may apply HEPA filter at the beginning, but the TB supposed to be in negative rooms. Not like the COVID. The COVID, we may deal it with the HEPA filter, it's okay. But TB, open TB especially, can't be in HEPA filter for a long time. We may like temporary solution, but it's not permanent solution. And with full PPE. Also, we have the urinary infections, respiratory infections. Okay. I think we talked about that. We'll talk about the things one together. Also, we talked about airborne precautions. Okay, airborne precautions. Now we will talk about contact precaution we have. So contact precautions, usually only we need the gown and gloves only the barriers that prevent the contact with the patients. Okay, this is the contact precautions. Also, we have the droplet precautions. We have to use plus the gloves and surgical and plus the gowns, yellow gown or the cleaning gown. We have to do the mask. We have to do the mask. While in respiratory and airborne, we have to do the N95 mask, and also in 95, yes, in 95 mask, yes. This is in the airborne. If we have beard, usually you have to do the fit test for your mask. It's not about picking, this is 95, I will pick it for myself. Now you have to do the fit test, and you have to get the Pixel certificate, which shows that what's the mask suitable for you. In case we don't have the fit test and we are asthmatic and we have beard, if you are beard person, you can't, the N95 not fit for you. You have to use the bubber. Yes, Hatun, yes. Guys, you have a nice information. Okay. I think the patients will be safe. We hope so. Yes, we have to use the bubber. Okay. And the bubber can't be used. Yes, Iman, helmet. The helmet for the bubber can't be used for all persons. You are disinfectant, give it to your colleague now. Every helmet is a responsibility of each one. So if I have helmet, I have to use it, disinfect it, keep it in my cabinet. I will not endorse it to anyone. This is the right way. Some of them, they just disinfect and handle it to their colleagues. It will be dangerous for us. So we have to keep a buffer there at the unit, and every staff who doesn't have a 95 or fit test, they can't wear the 95 for any reason. They have to use the buffer with their own helmet, not for someone else. Yes. Okay, then we'll be, we finished the precautions now. Also, we have, I think we talked around the infection control, but we didn't maintain the same one in the slides. But some of information is supposed to be mentioned to get and disseminate the benefit and the knowledge as well. So one of the strategies also, respiratory infection, the Ministry of Health, they put a strategy for respiratory infection. They put it for urinary infections as well. They put it for surgical site infection, also bloodstream infections. Okay, this part we need to participate it together. What's the bundle for respiratory infection? We have to do it for the patients. The one who's in VAB, nice. The one who's in ventilator. Yes, Hatun. Ventilator-associated pneumonia. If any patients on ventilator, we have to use the bundle. Okay, you have to use the bundle. we don't have, maybe we have, every hospital, they have their own bundles, but mostly, even globally, they use the same criteria. They are focusing on peptic ulcer prophylaxis. They're focusing on their elevations. Most of the institution or health institutions, they go on the same way. They are looking for the same things. Okay, what about urinary infection? What's the bundle we are using for urinary infection? Cauti, nice. Yes, catheter-associated urinary tract infection. What about surgical site infection? Okay, who will be on the lead? SSI bundle, okay, SSI bundle for surgical. What about bloodstream infections? The patients on central line. What's the bundle we are using? If yes, CLAPSI, yes, nice, Hatun. Okay, CLAPSI, central line associated bloodstream infection. Okay. So what's the purpose? Why do we keep these strategies? Why we follow them? Why, if I have a patient on ventilator, why do I keep bundle? If I have patients on IFC, why do I keep the bundle for IFC? Also bloodstream, like if I have patients on central line, why do I keep the CLAPSI bundle there? CAUTI, okay? Why do I? This is the purpose, to identify and reduce the risk of acquiring infection among patients, staff, contact workers, volunteers, okay? To monitor, yes, to prevent the infection, okay? Also, we need to see the readiness, okay? I have to review them. Do the patients need them or not? Daily, I have to do review for them. The patients are intubated. Do I need the intubations? Do the patients need the intubation right now, or do we need to extubate him? We have to ask ourselves these things. If the patient's long time on the ETT, on the endotracheal tube, what shall we do? What shall we do? If I do like daily assessment for the patients and it's hard to extubate him, what's the second one? We may think in the tracheostomy tube. In the tracheostomy tube, okay? We may think in the tracheostomy tube because it's less infectious and get the less infection than the ETT. And easy to extubate and weaning from him, from the ventilator. And it's easy to return if the patient is tracheostomized. But we have to think in the tracheostomy, if there is poor prognosis within 3 weeks, 2 weeks, then we have to think about the tracheostomy if we can't extubate the patients. Risks are related to the mode of transmission. Yes, depends on the risk of depends on the risk or the transmission, the mode of transmission. We may classify them. As we mentioned, if the infection will be gotten from the air, we will call them airborne. Okay, depends on the mode of transmission. Okay. Airborne and droplet risk. Patient with respiratory disease does not properly isolated. Okay, this is the risk. Okay, here we could say here, identifying risk of infections. Why do we get these things? Because sometimes affected patients may represent a risk for other patients. For example, I didn't do screening well for the patient, or I admitted patients as chest infection, pneumonia, aspiration pneumonia, or what kind, anything. Then we discovered we didn't diagnose him well. Then we discovered the patient has TB. So this is one of the identifying risk of infection. So guys, please admit, before admitting the patients, you have to screen them well. And if there is 1% chance the patient is infected, I have to work with them as they are infected till I got an opposite result. For example, if this is query meningitis, query TB, query COVID, query H1N1, I have to deal with them or treat them as COVID. I have to do N95, everything, till I do the PCR for them or rapid test to make sure they are negative. Then I can treat them, depends on their situation. Also here, patients with respiratory disease not properly isolated because they didn't properly diagnose it. Also, no good screening for them. Staff or visitor with unidentified respiratory illnesses. So some of them, they are coming with TB. Later on, the other people, they got infected. Also measles. These days, I think the measles, like maybe 5 months ago, there is some percentage and some cases with measles has been appeared. Also chickenpox. Chickenpox, yes, it will be went viral quick and fast. Unavailability of negative pressures in airborne isolation rooms. So we told you that if you don't have negative pressure rooms, you have to use the HEPA filter. But some diseases like TB, we need to seek the negative room as soon as possible. Even though, because these days, I think the TB and the other things, we need the negative rooms. So in the infrastructures and the administration of the hospital, they have to work with the maintenance, medical maintenance, and general maintenance to create a room as negative pressures in each units in case we have TB, we have something else, we have to isolate it there to prevent the transmission of infection to another patients. Here also contaminated ventilation or water systems. Yeah, this is mainly we say them in the conventional dialysis. So we have to do checking for the water sanitation. Direct contact risk. Okay, what do we mean by direct? Direct, it's no barrier. Direct, breach, protective barriers, gloves, hand to hand, shaking hands without hand washing. Do like assessment for the patients without wearing gloves. This is direct contact risk. Indirect, what do you mean indirect? There is some barriers between. So I touched the patients without gloves, or I came along to the station with my gloves. I touched the computers. My colleague came later on and they touched the computer. So the computer is the media. Here we call it indirect contact risk. Okay, here indirect. So we have the 5 moments. We have 5 moments. I have a poster later on. I will show it to you. It's about the 5 moments. When we will do the hand hygiene, we can't skip. If we pass by these things, we have to do the hand hygiene. Okay. We'll be moving now to the second slide. Slides is clear, guys? Do you see them? Okay. Let me. Okay, thanks for informing, guys. Let me stop sharing. Okay. Sorry for this technical issue. Yes, here we call the indirect, but I will share again. Now is okay? Thank you so much for informing. Also, we would like to thank the people at the support center. Okay. Okay, indirect contact risk. This is, as I mentioned before, if we use like a stethoscope. Nowadays, we have the disposable stethoscope, or even we use the stethoscope, we have to disinfect them. Thermometer, we have to put the cover, thermometer cover. I can't use them directly to these patients, then remove it from this one and use it for the other one. Even you have a shortage and you don't have them, you have to disinfect these things. Blood pressure cuffs. We have single use. After the discharge of the patients, you have to discard them. Don't use them for the other patients. Also, contaminated endoscopies, not properly sterilized between patients. So, unsterilized surgical equipment during failure of autoclaving or inappropriate monitoring of sterilizations. Injuries with contaminated sharps, exposure. These things we call them indirect contact. So, common vehicle transmission risk. This is like a barrier. One thing it's not related, like not direct transmission or indirect. We call them common vehicle transmission. Like if the food and water supply has been contaminated, it will affect on the patients. Also, contaminated dialysis water. Anything, any contamination of the machine itself, swimming pool water. This is, we call them vehicle transmission risk. Also, general patient risk factors, admission to intensive care unit, loss of natural barriers, presence of devices. Also, if there is a presence of devices, such as we call even for the ATT and IFC and central line, we call them devices. Presence of them, it may cause or it's a media to get an infection. So kindly remove them and review the necessity of them daily and remove them as soon as possible. Risk of surgical site infection. If inappropriate patient preparation, okay, it may cause risk. Showering and hair removal with a clipper just before operation. If we didn't give inappropriate antibiotic prophylaxis, there is one strategies and protocols from the MOH. They give you suggestions if you'll go For orthopedic surgery, GS surgery, they recommend some antibiotics for you. Okay. Defective patient skin preparation. So we didn't do patient skin preparation good. Inadequate personnel hand and forearms antisepsis, gloving and gowning. If we didn't do this properly, you may, this is one of the risks that get infection, especially for the surgeons. Failure of equipment sterilization. As we mentioned before, if there is failure at sterilization department, and if they didn't do it on the right way, you may get infection. Poor engineering control of operating theater. Yes, sometimes the AC, sometimes the pressures, everything in the operating theater. If there is poor engineering control, maybe if there is dust, not clean well, the patients will get infection. Unnecessarily staffing and movement in operating theater. Some people, they are getting into the OR without full sterility. They are breaking the sterility there. Even their presence is now important, but they are getting in. This is one of the causes. Also, contaminated or dirty surgeries. Like in the bowel surgeries, it has more risk, okay, than clean ones. And clean contaminated surgery also. Head and neck surgeries. Length of surgery more than 2 hours. Also, the surgeries that take long time, also there is a chance the patients will get infection. Patient with uncontrolled blood glucose before surgery. Patients will go to surgery with high RBS, uncontrolled DM, uncontrolled RBS. This is will cause sepsis in the blood, as you know. So control the blood glucose before sending the patient to the OR, isn't it? Also, patient with the remote infection as dental abscess. So patient has a dental abscess and you're gonna extract the teeth. Now you have to treat them till the infection subsided, then give him another appointment for the review and another appointment for the for extraction. Risk of hospital-associated pneumonia, which call it HAP. And the one coming from the community, what we call it? CAP. So we have HAP and VAP, the one coming from the ventilator, and CAP, community-acquired pneumonia. Depends. If the patients came from home with pneumonia, we call it CAP. It means community-acquired pneumonia. If the patients develop pneumonia in the hospital, well, we say it's HAP. But if the patient in the hospital and on a mechanical ventilator, we call it VAP. Use of devices such as nebulizers, ET tubes, bronchoscopies, spirometers, tracheal intubations for mechanical ventilation, continuous mechanical ventilation more than 3 days. It's risk. At risk to the patients may get the VAP, okay, ventilator-associated pneumonia, or the orogastric or nasogastric tubes, okay. Frequent change of mechanical ventilator circuit. If you frequently change them, there is a chance you break the circuit itself. I mean, you open up a place where the infection can get through. So some of them, they are recommending the closed suctioning machine. Use of antacids and H2 blockers increase colonization of stomach. So these things may help or fasten the developing of pneumonia. Also, smoking, alcoholism, and drug abuse. All of these things help to develop pneumonia in the hospital. Risk of urinary infections. What about the risk of urinary infection? The presence of urologic abnormalities, that's bladder outlet, obstruction from enlarged prostate, instrumentation of the bladder, lack of male circumcision, promiscuous sexuality and sexual offer activity, indwelling urinary catheters, recent genitourinary surgery. Neonates have high incidence of UTI in their first year of life. Females are at high risk due to their short urethras. Greater risk factors for upper tract infection affecting ureters and kidney include uncontrolled diabetes, pregnancy, and immunosuppression, previous pyelonephritis, structural abnormalities of urinary tract, and UTI symptoms lasting more than 14 days. All of these reasons may help or may develop the urinary infections. What about healthcare workers? Exposure risk. Exposure of healthcare workers to airborne infections in the following situation. How the healthcare workers getting sick or getting infection. First of all, admission of patient with unrecognized airborne infection in regular room. So patients supposed to be in negative rooms, we had admit him here in a regular room because we didn't do proper assessment, cleaning, and diagnostic upon admission. Secondly, failure to use appropriate mask in 95. We encouraged you guys before, or like in the previous slides, don't use N95 directly, just it's airborne. Use N95, and there is many companies for N95. Use the one is suitable for you. If you didn't do the fit test for your mask, use the proper and use your own helmet. Don't use the other's helmet to care for patients with airborne infection. Also, we could say healthcare workers with unrecognized incubating airborne infection presence on duty. Already, maybe not from the patient itself. Maybe already they have infection. They don't discover themselves. Later on, it disappear and open up. Visitor infected with airborne disease as measles, chickenpox, or TB. Visitors, they are coming to the hospitals with these things. They will spread their infections to the healthcare workers. Also, we are not keeping barriers with the visitors. Inadequate ventilation and engineering control of the isolation room. So we said that we have to do checking for the isolation daily, whether they are okay or they need maintenance. Make sure the monitors there are green all the time and it shows the pressure in negative. -2 and more. This is the normal. If you find them -1 or 0 or in positive, you have to report. And you have to know this room is not working, is out of order. Contamination of ventilation system with waterborne bacteria, okay, like Legionella that have contaminated water system. Potential exposure to blood fluids, secretion. So if you are exposed to blood fluids, what shall you do, guys? Exposing on the body. You have to do hand washing immediately, and you have to change your PPE. And we encourage you to use the PPE all the time, depends on the patient conditions and the mode of transmission or the precautions for the patient. In case there is needle stick injury, there is some fluid spilled into your eyes, you have to wash them immediately, and you have to go directly to the staff clinic to do the other investigation. Okay. Contact with blood and BF without protective barriers. Breaks of barriers or malfunction of safety devices as laboratory safety cabins. Health care workers being unaware of infection risk. So this is lack of education, maybe, or maybe they are dealing with patients with herpes zoster on the back without gloves. Inadequate hand washing. They are not doing the proper hand washing. That's why they are getting some infection. Also, they are dealing patients with hepatitis. Handling of contaminated linen, biohazards, material without precautions. They are carrying and they remove the linens to the dirty utility room without gloves. Just they are taking from they assume the patient is clear. However, the patient is infected. Exposure risk to blood-borne infections through sharp injuries. As we mentioned, if you got needle stick injury, directly you have to write an OVA and you have to go straight away to the staff clinic at your departments, or you have to pass by the emergency department in the evening and night shift if you don't have them in the morning shift. Exposure without vaccination, dealing like with the TB or hepatitis without got the doses there. Before getting to the work, you have to make sure you are taking also the COVID, dealing with patients with COVID without taking the vaccination. Make sure you are getting the necessary vaccination before getting to the work. Food poisoning as well. Also, there is some risk that coming from the visitors and family. As we mentioned, some of the family, they are coming with COVID, coronaviruses, or TB. We don't know them. Suddenly, the infection will be spread. Okay. Or some risk that will be transmitted to the visitors or family if they are not following the standards and the precautions. Okay, because they are the relative, they are not thinking, now we know he's okay, she's okay. Then they are getting into the isolation rooms without full PPE, then may develop some airborne infection. Here, the first poster, now with the poster. Here, the first poster, how to do hand washing. Okay, guys, we have to make sure about the hand washing. We have to follow the steps. Also about the duration. Okay, if you are using the water and soap, you have to use 40 to 60 seconds. Okay, while if you are doing the hand rubbing with the alcohol gel, you have to do it from 20 to 30 seconds. You have to do the same steps and make sure this label will be stuck near the sinks, the washing, the basin, and at the rooms. make sure it's available all around the units. In case some of them, they forget the steps, this poster may help them. Also, your 5 moments for hand hygiene. This is the 5 moments. I think you are aware about them, isn't it, guys? Do you? Yes, nice. Okay, so we have how many before? We have 2 before and 3 after. Once you do these things, you have to do the hand washing. The first two, it's before. Before touching the patients, I have to do hand washing or hand rubbing. Before clean or aseptic procedure, I have to do hand washing or hand rubbing. Before touching the patient, hand rubbing. Before, like aseptic technique, aseptic procedure, you have to do hand rubbing. And we have 3 after. After touching the patient, you have to clean your hands, hand washing or hand rubbing. After body fluid exposure risk, you have to clean. After touching patient surroundings, if you touch the monitor, if you touch the bed, if you touch the cabinets there, anything belongs to the patients, if you touch it, you have to do hand washing. Also, we have to keep this one alongside with the hand washing steps. Also try to distribute them in the units. Okay, here the fab bundle we are using at hospital. We have at the hospital different style or different design, but the elements inside the same one provided by the MOH. I couldn't find the one for the MOH, so I brought you one, guys, but just to get an idea. So any patients on mechanical ventilator, we have to put this bundle for him. No excuse. For example, if the patient's on mechanical ventilator, I have to ask myself, does he have DVT prophylaxis or VTE prophylaxis? Yes, he's on heparin. He's on Clexane. He's on pneumatic, okay, pneumatic compressor or the DVT cuff. Yes, then I can make tick yes. This should be done daily. Then I have to see the head of the patients, the head of the bed. Is it in 45 degrees or less? Shouldn't be in the flat position or supine position. Because if you put your patient on supine position, for sure the patient will develop VAP, ventilator-associated pneumonia. Always keep the head of the bed up to 45 degrees. Try not making below 45. Also, we have to ask ourselves about the peptic ulcer. Do the patients on omeprazole as a prophylaxis? Yes. Then I have to take tick. Yes. Then I have to move about. Did I do the sedationification? Do you know what does it mean, sedationification? What do we mean by sedationification? Yes, 30, yes, Hatun, yes. Sedationification, when we got an order from the physician to stop the sedation to assist the patient, how's the GCS to know is the patient okay? After X-ray, the chest is okay. Then we have to think, need the tube or no? Yes, we have to stop the sedation. Okay, we have to stop the sedation to assess the GCS, Glasgow Coma Scale. If the GCS is okay, patients almost obeying the comments, then we have to think the others. We have to see the PPGs, blood gases, X-ray, no other contraindication to extubate, then we have to extubate the patient immediately. Okay, so we have to do sedationification or readiness to extubate. Also, there is what we call it oral care. We have to use the chlorhexidine mouthwash for the patients who's a mechanical ventilator to prevent the fungi and all the fungi that's may develop in the mouth. Okay, this is the FAB. Also, we have the checklist for the CLABSI, Central Line Maintenance Bundle. Okay, if I have like central line maintenance for the CLABSI, here also there is a different forms, but every hospital has their own forms, but mostly the forms goes together. I have to disinfect the boards of, if I have patients on central line, I have to keep the bundle for CLABSI, okay? Usually we are using the one from Ministry of Health. I think most of the hospital, they are using the same bundle and it's mandatory. And one of the strategies to make the infection or the CLABSI zero. Okay, usually it's about we have to select the site of insertion. Usually, if the patient is pedia, we'll go femoral. But if the patient is adult, the femoral is not preferable because maybe get infection there. Usually, you have to go to the subclavian or jugular veins. These are the preferable sites for the adult patient. Also should be done under ultrasound guided machine and should be done with a qualified physician. We have to keep the adhesive plaster there, the dressing plaster on the central line with the chlorhexidine dressing. Also, we have to keep the boards of central line closed all the time. Even I try to use them, I have to disinfect them with alcohol swab, and I have to keep them little bit to be dry, then I have to use them. Also, I have to disinfect them after using. Okay. Usually we have to do aseptic technique with them, whether for insertion or for dealing with it. Can't be with the clean gloves. I have to do surgical gloves with full technique because you are dealing with the large vein and large catheter. If you break the rules of infection control, suddenly the patients will develop infection. This is for the CLABSI. Also, we do for the CAUTI. Okay, so any patients on Foley's catheter, we have also to assess them daily. Do they need or they don't? If they can void freely and they have to, and they are ambulatory, we encourage to remove it. We don't insert any IFC unless the patient needs. Also, we have to keep up to 70%, no more than. Then we have to drain the urine bag. Don't make it, otherwise the urine will be returned to the urinary bladder will be full and no chance to getting out, and the urinary bladder full and the urinary bag is full as well. There is a chance the urine may return to the kidney through the ureters, and they developed some infections there. Also, we have to secure the urine bag. Don't keep it like freely moving down. It may cause injury to the patient. Also, if the patient is restless, we have to restrain them, whether physically or chemically with physician order. Otherwise, maybe they will pull out pull out the Foley's catheter and may cause an injury for their urethra. Okay, so usually we have to keep an eye on any contraptions for the patients, whether central line, whether ATT, whether IFC. Also here we have the SSI bundle. SSI bundle, as we mentioned, one of the bundle that's the MOH Ministry of Health in Saudi Arabia encouraged us to implement them. They do another but same of this one, but different forms. But just to give you an idea, we have a SSI bundle. So usually we are dealing about giving the patient antibiotic, good shaving, skin preparation before the OR, and we have to control the temperature and RBS, and we have to follow them, the RBS and temperature post the OR. And here we have some procedures like pre-hospital bowel preparation, like we mentioned before, giving enema. If prescribed chlorhexidine scrub, we have to wash the body with the chlorhexidine. Pre-operative checklist. We showed you the checklist we do before the OR. Make sure about consents, RBS, availability of blood, everything should be signed with the unit nurse and the receiver. The OR nurse will sign as well. Intraoperative, we have to do the timeout there, okay? We have to do both. We have to do everything to make sure this is the right patient, right site, right procedure. Also, we have the post-operative. We have to monitor. We have to monitor if there is any increasing gut temperature for the patient. Also about the RBS, if it's not controlled, we have to control that. We have to seek the help from the specialized units. Okay, here we reach to the end. Thank you so much for this part. Okay, now we finished the fifth one. Only remaining for us the sixth goal, and the sixth and the last. Okay, almost we are there. So we'll be moving. Okay. Now we will be showing you. Is it the slides shown to you or not? Do you see them? Do you see the slides now? No. Okay. I will stop sharing. Okay. What about now, guys? Visible to you? Okay, thanks. Not yet, Maha. Do you see the slides now? Yes, okay. Okay. Now, what about now, guys?
Good. Okay. Thanks. Okay. For risk. Okay. This is the last one of the goals. We'll be talking about them today, which is for risk. So we have here some important definitions. You have to pay attention on them to know, this is near fall or a fall? Okay. And what we know by assisted fall. Okay, a fall is defined as an event which results in a person coming to rest inadvertently on the ground or floor or other lower level. So if we find the patients laying down on the floor, this is fall. Okay, it's a fall. But if you find the patients about to fall and he didn't get to the floor, we call it near fall. An event in which a person feels is imminent but avoids by this compensatory action, such as grabbing a nearby object. So if the patient's about to fall, then he holding the bed. We can't say this is a fall, we call it near fall. It means almost the patient's fall, but he didn't. What about assisted fall? Assisted fall occurs when the patient begins to fall is assisted by another person. Near fall, the patient assisted himself by himself, or they assisted themselves by themselves. While the assisted fall, the patient has been assisted by someone else, by another person. Here's the difference. Clear to you? Okay. Occurs when the patient begins to fall is assisted by another person. So what about fall risk assessment? We have to do, if you are a nurse, you have to do the fall risk assessment in every shifts, not only daily. Every nurse in her shifts or his shifts has to do the assessment for the patients. Also, there is some criteria to do reassessment. Even I did it in my shift, but there is some criteria. If it happened, I have to do the fall risk reassessment. We're gonna show them shortly. Fall risk assessment is a process of determining the patient's degree of fall risk. What do we mean by determining the patient's degree? I have to classify them, depends on their situations, into 3 categories or 4 categories if they are adult. We have to call them at risk, low risk, moderate risk, high risk. Depends on the score you are following, but usually, or I notice some hospital in Saudi Arabia, they are using the Morse fall. Do you use them, guys? Or if you use other than the Morse fall for the adult, mention it in the chat. Also, we use for the pedia Humpty Dumpty score. This is for the pedia, while for adult Morse fall. Okay, nice. I think we are on the same boat. Okay. So we have to do for risk assessment upon admission. Once they come to the unit, I have to do them to see they are high risk, low risk, at risk, moderate risk, this kind. What's the purposes? To institute an assessment process that determines the degree of patient risk to fall. So if I said,
or if I find the patient is at risk, I have to do some criteria with him. If I find the patient's low risk, I have to do some criteria with him or some precautions with him. While if I found the patient's moderate and high risk, I have to do additional precautions to him. So we will show you guys the things the next slides. Secondly, to implement preventive measures to prevent or minimize fall occurrence. What do you think? Why do we like saying assessing the patients against fall? Why do we guys do these things like assessing the patients against fall? The same thing, like why do we implement the bundles? Because we want to prevent the risk of getting infection. If you get infection, the length of stay will be extended and you will use more antibiotics. Then you will cost the institution more monies and to use the antibiotics. Also if the patients fall down. If the patients fall down, okay. If the patients fall down, also he will stay longer in the hospital, need maybe surgeries, another interventions. Maybe the skull has been affected because of the fall. Maybe the femur, he has femur fracture or any kind of fracture. Then instead of he's treated for this reason, he will be treated for because of the fall. So we have to assess our patients. How much do I need to give him score? So all patients served in the hospital must be screened for fall risk at the port of entry in the hospital. So if the patient's admitted through the emergency department, the ER nurse has to do the risk assessment in the emergency department. Also, if they are admitted in ICUs or in the general wards, also the nurses there, they have to do their own assessment. Also, all inpatient must be initially assessed for risk of fall within 30 minutes from the time. For example, no more than 30 minutes or no more. Some institutions, they are saying no more than 1 hour. So within the first 30 minutes of arrival or within the first hour of the arrival, I have to do assessment for my patient. I have to document it. And I have to do the proper way. So assessment on admission form, appropriate risk tool. Here we go. We use for the adult Morse 4 risk scale, and maybe there is another hospital they are using another scales to assess the fall. And also there is some Morse 4 risk scales, little bit varies from one to another, even for the scores. This is what I noticed, some of them. But in general, we are doing Morse fall, and both of them, or most of them, they work towards one goal, to prevent the fall. Whatever the criteria there they are putting, but all of them, they are aiming to prevent the patients from fall. So for Morse, as we mentioned, for adult, so we consider the adult from 14 years old and above, while the children we use for them Humpty Dumpty. This is 13 years and below. And also, always we are saying depends on the institution you are working in, and just double check with the policy and procedures. Some of them, they are considering 12 and below. This is children. But at least we have one for the PD, one for adult. So usually the Morse fall has history of fall, then it has some score. If he has history of fall, the score will be greater than the one if no history. If there is the secondary diagnosis, Okay. If or more than one medical diagnosis, the score will be greater than if he or she has one. The presence of ambulatory aid like cane, crutches, or walker. If the patients use them, the crutches or cane, the score will be greater. Clutching onto the furniture for support. He can't ambulate alone. He has to use the side rails on the corridors. Then we can say he will get more score. Also, if the patient's on IV fluid, or he has like cognitive dysfunction or mental status dysfunction, or he has gait or mobility functions if he has impaired that gait and mobility functions. If he has IFC, also this we have to consider them. Okay, so this is one of the this is the Morse fall, but maybe varies from one hospital to another and from one country to another, but usually they will go on the same way. So here, as we see, if the patient has history of falling, if no, we give them 0. If they yes, we give them 25. For example, okay, there is history 4, I will give them 25. Then if they have secondary diagnosis, I'll give them another 25. If they don't have 0, we'll consider it they have 25. It means 50 now. So here high risk, 45 and higher, this is high risk. You see the legends down. Depends on the score you give. Depends on the score you will get. This is the Morse fall. Always also the Humpty Dumpty fall risk scale for children. We mentioned 13 years old and below, or from 0 to 13, should be used the Humpty Dumpty for risk scale for children. The criteria: age, gender, diagnosis, cognitive impairments, environmental factors, response to surgery, medication usage. Okay. But okay, this is the Humpty Dumpty. Here they are giving, depends on the age. If less than 3 years old, we give them 4. When they are getting older, the score will be less. So if they are 13 years and older, we'll give them 1. When they are be smaller, the greater number of score. Even for the gender, if you are male and a child, you'll get 2. While female, they are get 1. Maybe the female is more quiet than a male. Oh, then maybe this is true. Okay. Each assessment has corresponding points or score. Total score shall determine the degree of for risk. So here we go for Morse fall scale. This is the score we may give to the patients. If the low risk 0 to 24, this is the low risk. If the patients got 25 to 45, moderate. If high risk, 45 and higher. While for Humpty Dumpty for scale, high risk 12 and above, while low risk from 7 to 11. We have some criteria here. We have to give them like high risk without giving the score. If the patient blind or preoperative, and we start MPO, continuous sedation, post-op or post-anesthesia, epilepsy, all patients for dialysis, we have to give them directly, blindly, we have to give them high risk. no need to go with the criteria. While if the patient's quadriplegia or GCS 6/15 and below, we have to give them low risk. If I have patients on high or moderate risk, I have to add additional to them. Okay, keep them near the nursing station. I have to orient them. Okay. Also, patients, if they fall, we have to reassessment them within 30 minutes, every 30 minutes of the occurrence, and every 4 hours for 24 hours. Yeah. Within 30 minutes, I have to do reassessment for them if there is fall. Then, or if they receive some diuretics or anesthesia, I have to reassess them within 30 minutes, then every 4 hours till I complete 24 hours. After administering narcotic, diuretics, laxatives, analgesic, anticonvulsant. For all patients with moderate and high risk, bed must be relocated closer to nursing station if possible. All patients with moderate and high risk of fall must be checked every hour for side. Always we have to keep side rails up. Bed position always to be the lowest position. While the surroundings, we have to orient them about the surroundings, and we have to make sure about no slippery area. While the universal interventions, if the patient's at risk only, I have to orient them only to the environment, place bed in lowest position with the brakes locked, place bedside rails up, and consider use of additional safety and precautions. Use non-skid footwear whenever out spoiled if available. Also, we have assist elimination needs, assist as appropriate, ensure nurse call pill and patient's items are within easy reach, keep walkways obstruction and spill free, assist for adequate lighting, leave night lights on, educate patient watcher about fall protocol intervention, evaluate effectiveness of medication, monitor or for orthostatic hypotension. If the patient's suddenly getting up and there is a dizziness, we have to assist them. Encourage use of assistive devices when they need. Walker, wheeled walker and cane, crutches, depends on the patient's situation. Reassess patients' ambulation status daily. So if we have a patient's moderate and high risk, we have to keep orange dot at the file and just behind their the head of beds to just orient them or just endorse to the colleagues this patient's moderate and high risk. We have to keep an eye on them to prevent the fall. Also, we have to consult and cooperate with the physiotherapist, occupational therapist, if they have, the patients have issues at gait and balance problems. Also, we have to keep the room of the patients on high and moderate risk just close the nursing station. Post-fall, okay, we have to assess patients and provide immediate care, notify medical team to review the patient and document a plan of care. Also notify head nurse and overall nurse supervisor if there is incidence of fall. Document. We have to do general assessment, inform watcher to always be present. Okay. Also, we have to carry out physician orders and closely observe patient, notify multidisciplinary plan. Also, if there is documentation, we have to do it for the patients. As we mentioned earlier, within the first 30 minutes, And some hospital, they are doing within the first hour. Also, if there is reassessment, we have document them. If there is risk of fall or if there is real fall, we have document them as well. Communication. Communication usually, as we said, during the orange dot, we have to visualize communication tools, flagging them with orange dot. As we say, hey guys, this patient has high or moderate risk, be cautious about them. And we have to monitor them closely. Here the same, we said like reassess within 30 minutes and every 4 hours for 24 hours from the incidence of fall or receiving any one of the laxatives or diuretics or analgesia for first time. We have to do the same. After administration of medication like antihypertensive drugs, hypoglycemic drugs, diuretics, laxatives, analgesic IV, we have to do reassessment within 30 minutes, then every 4 hours for 24 hours. We have to educate patient watcher related the assist fall and its preventive measures, including environmental safety measures upon admission. We have fill up refusal form. If the patient's not following or the family not following the precautions we instructed them to do, we have asked them to do the refusal form. This is one of the things that may help you in the future in case of the falling. Thank you so much for listening, and I hope you enjoyed the lectures. And if you want anything, if you want to ask about anything, let us know. And we are sorry for those people that complaining the lecture is really it's heavy topics and can't be done in a quick time. But anyway, I think we got like 1 hour break. This may affect on the timing as well. Now I will stop sharing and we'll see with the admins if they may provide another things. Kindly don't leave. Just we need to, I need you like for 10 or 15 minutes only. Okay, just we need 15 minutes, maybe by, now it's, yeah, almost by 3:30 or almost by 3:40, we're gonna finish this seminar. Just I want to just to show you some posters here. Just we are working on them. And we appreciating your presence really, and also the admins will work on the attendance as well. I hope we added one thanks to your knowledge. And if you have any questions till I prepare, we prepare the posters that will be shown to you shortly. If you have any questions, don't be hesitate. Okay, just give us some seconds. No worries. Appreciated for all of you guys. Abdulaziz, Fahad, Abir, Eid, Abdullah, Salim, yes, Hamda.
my pleasure, my pleasure. أبرار الصبحي. Okay. Welcome, Dr. Abdulaziz. The poster is shown now.
Assalamu alaikum. Good
Alaikum
afternoon,
salam.
everybody. I hope I have this poster. It's about managing patient safety culture to improve care quality. Inshallah, will not take more than 10 minutes or less, يعني faster, inshallah. بسم الله. ما أدري الصوت واضح؟ Okay. طيب. An abstract about this poster, inshallah. Developing a robust patient safety culture is crucial for enhancing healthcare quality and outcome. This review examines key strategies for managing and qualitating a safety-oriented organizational culture with healthcare setting. Effective leadership, open communication, and a blame-free environment are identified as foundational elements. A training program to improve staff competencies along with the implementation of safety reporting systems and incident analysis are also discussed as crucial components. Additionally, the review highlights the importance of aligning organizational process and initiative to reinforce safety priorities while fostering a culture where the patient safety is the top priority. Healthcare providers can drive continuous quality improvement, reduce medical errors, and deliver safer, more reliable care. Ultimately, a strong patient safety culture empowers clinicians, engages patients, and helps build trust in the healthcare system. This is about the abstract. The main objectives for this poster is to identify the role of the patient safety culture in the improving care quality and to introduce a framework to enhance patients' safety culture in healthcare settings. The methodology for this study using the scoping review approach. This research focused on all the articles that and papers published on the patient safety culture and care quality improvement. In fact, the research yielded 17 studies. Then 6 studies were only suitable for study. about integrating the patient input into the safety culture. The patient safety culture is focused on the aspects of organizational culture that relates to patient safety. It is defined as a pattern of individual and organizational behavior based upon shared beliefs and value that continuously seeks to minimize patient harm, which may result from the process of care delivery. Integrating patient feedback into safety culture initiative is crucial for improving patient-centered care, and quality key strategies include expanding patient engagement opportunities, incorporating patient perspective into safety investigations, empowering patient as safety patterns, closing the feedback loop, and aligning in intensive and accountably by activity seeking and responding to patient input. Healthcare organization can enhance organizational learning, address and system level factors, and drive continuous safety improvement. We have a figure of patient safety and quality ecosystem. This figure, there are four inspectors, we can say, a blame culture and liability fair culture and hierarchical culture or better statistic culture. This four will be like inspector for the main patient safety and quality ecosystem, represented by patient awareness culture and patient centric culture, reporting culture, speak up culture, safety culture, system culture, learning culture, quality improvement culture, to reach to that level of patient safety and quality ecosystems. About determinants of the relationship between the patient safety culture and care quality, organizational factors, leadership component, a strong and a visible leadership support for patient safety is essential. Organizational learning, a culture of continuous learning and improvement factors as a safer environment, resources allocation, adequate safe staffing, training and technology are crucial for patient safety. Organizational structure, clear rules and responsibilities, effective communication channels, and teamwork enhanced safety. That's about the organizational factors. About the staff related factors, education and training. Well-educated and trained staff are better required to identify and manage risks. Workload and burnout, excessive workload and burnout can negatively impact patient safety, the number of hours and the load of work, and job satisfaction. Satisfied staff are more likely to be engaged to patient safety intensive teamwork and collaborations. Effective teamwork important, improve the communication and coordination of care. Care can enhance safety, patient education. Educated patients also are more likely to be active patterns in their care. Patient expectations, understanding patient expectation can help identifying potential safety risks. Also about the system-related factors, reporting system, effective incident reporting system facilitate important just culture, a culture that balance accountability with a system important. Technology, advanced technology can support patient safety initiative, regulatory environment, a clear and constant regulations can drive a patient safety environment. About the mediating factors, communication, effective communication among healthcare providers is crucial for patient safety. Teamwork, collaborative teamwork enhances patient care and safety. Error reporting, open and honest reporting of errors is essential for improvement. Patient concerned care, focusing on patient needs and prevent performance and improve safety and quality. Regarding the framework to improve the patient safety culture, we'll see some various like culture, process, technology, as we mentioned in the previous part. Increasing the awareness of and the trust for everybody, patient and staff, and increasing from the level of very low up to low and increasing to the moderate and high and very high. We're hoping to reach that level of very high awareness and good framework to improve the patient safety culture. Conclusion and recommendation. This review highlighted the crucial connection between patient safety culture and the quality of care delivered. For example, a culture that prioritizes infection prevention and provide adequate resources for hand hygiene can lead to a lower rate of hospital acquired infection. Also, a strong safety culture that emphasize open communications and a double checking medication order can sufficiently reduce medication errors, leading to improved patient outcomes. By prioritize a positive safety culture, healthcare organization can sufficiently enhance patient outcome. This involves fostering a culture of open communications, teamwork, accountability learning, and patient-centered care. By empowering staff to speak up, report errors without fear, and continuously learn from mistake, organization can create a safer environment for both patient and healthcare providers. Ultimately, investing a patient safety culture lead to improve patient satisfaction, reduce medical errors, and a strong healthcare system overall. Thank you, everybody. Thank you for listening. If there is any discussion or any question.
Thank you so much, Dr. Abdulaziz. It was a nice and informative poster. To be honest, we like it, especially when conducting a scoping review. And yeah, there is many points you mentioned there at conclusions. I think it's linked as well to maybe the topics we introduced earlier, like about reporting to the speak up and encouraging the staff, empowering them to report about any incidents and learning from their mistakes. The supplies, provide a good supplies. All of these things will contribute positively on the patient safety. This is only the things I think I would say to you. Really, it's admiring and inspiring.
No question. Thank you. Thank you.
I think we reached to the end once the Dr. Abdulaziz presented his poster, and I would like to thank you, all of you guys, for attending and being a patient with us this day. Hope to see you soon, and I would like to ask to thank the Future Vision as well for health training. Wish you the best, guys, and see you in coming lectures. Anything to be added from Dr. Abdulaziz or Future Vision? Okay, thank you so much, guys, for your attendance. Hope to see you in next coming lectures. May Allah bless you guys. As-salama.